So good morning everyone. We are welcoming you to the third day of third annual Congress of Immuno-Oncology Society of India. We are overwhelming with your responses and attendance. Now I request our organizing secretary, Dr. Jyoti Bajpai ma'am, to provide the opening remarks. Over to you, ma'am.
So thank you very much, Rekha. And on behalf of my co-organizers, Dr. Atul Sharma and Dr. Amit Awasthi, it is an extreme pleasure and privilege for me to open this third and last day of the third annual Congress of Immuno-Oncology Society of India. And we are extremely delighted to welcome the faculties from overseas, national faculty, the participants. This year we could register near 800 plus participants, and most of our sessions are really packed with the people who are really interested, and also we are getting very good, very positive feedbacks. So thank you every one of you to make this Congress successful so far, and I'm hoping the third day will also bring into a great positivity. So with this note, I will hand over to today's Master of Ceremony, Miss Rekha, who will do the further announcements. Thank you very much.
Thank you, ma'am. So we are moving to our first session for today, for which I would like to invite our chairpersons, Dr. Dipankar Nandi sir, who is Professor, Department of Biochemistry from Indian Institute of Science, Bangalore, and Dr. Sharmila Bapat ma'am, who is scientist from National Center for Cell Science, NCCS Complex, Pune. Over to you. I request Dr. Nandi to provide the session introduction. Over to you, sir.
Okay, so a very good morning to everyone. I welcome you all to this very important session on vaccines targeting oncogenic pathways. This is clearly a very important area for all of us, and I have great pleasure in welcoming you all, especially the speaker, Dr. Nora Disses. May I request now Sharmila to please introduce Dr. Nora Disses. Sharmila, over to you.
Yeah, thank you, Dipankar. Good morning to all, and I thank the organizers for inviting me to introduce today's first speaker, Dr. Nora Disses, whose research I have followed and admired since long. Dr. Nora Disses is the Helen B. Slonaker Endowed Professor for Cancer Research, Associate Dean for Translational Health Sciences, Professor of Medicine and Adjunct Professor of Pathology and Obstetrics and Gynecology at the University of Washington. She is also a member of the Fred Hutchinson Cancer Research Center and director of the UW Medicine's Cancer Vaccine Institute. Dr. Disses is a member of the American Society of Clinical Investigation and the Association of American Physicians. She is also the editor-in-chief for German Oncology and a member of several committees and task forces for the American Society of Clinical Oncology, ASCO, and the AACR, or the American Association for Cancer Research. Dr. Disses is widely recognized as an expert in breast and ovarian cancer immunology, and it's in this context that I've been following her work immensely. And she's also one of the pioneering investigators who identified HER2-neu to be a tumor antigen, which led to several clinical trials to evaluate boosting the immunity to HER2-neu with cancer vaccines. Her research interests also lie in the discovery of new molecular immunologic targets in solid tumors, particularly the development of vaccines and cellular T-cell therapies for treatment and prevention of common malignancies. Most importantly, her group evaluates the use of the immune system to aid cancer diagnosis through the development of novel assays and approaches to quantify and characterize human immunity. Dr. Disses not only has several highly cited publications to her credit, but holds several patents in the field of targeted cancer immunotherapy and diagnostics. In addition to her research and clinical work, Dr. Disses holds many local and national leadership positions, and her work together supports her belief that all aspects of clinical cancer care, as well as cutting edge, must be brought to the table to improve outcomes for cancer patients. I look forward to her talk today and invite her to deliver the same.
Thank you for inviting me to speak today on vaccines for cancer treatment and prevention. My name is Nora Desis from the UW-Medicine Cancer Vaccine Institute at the University of Washington. We now know what we need for clinically effective anti-tumor immunity, and this is shown on the left-hand side of the slide as the optimal immune reaction. High numbers of cytotoxic T cells and CD4 type 1 memory T cells that can traffic to the tumor and penetrate deep into the tumor stroma. In fact, if you have a small tumor, having this type of immune reaction will predict that you don't relapse your disease. And even if you have a very large tumor, having this type of immune reaction will predict that you have a prolonged survival compared to other patients who have your type of disease. In fact, this effective immunity has been defined as an immune score, and it's quite predictive for many common solid tumors as being associated with improved survival. Unfortunately, what we really see in common solid tumors at the time of diagnosis is type 2 immune responses. Instead of Th1 immunity, which you see on the right-hand side of the slide, you see Th2 immunity as the predominant T cell infiltrate. And this is data that was derived from the Landscape of Immunity in Cancer project through the TCGA, where you can see here, I'm just showing you breast cancer and gastrointestinal cancer across many different subtypes. You see that, again, the predominant T cell infiltrate, no matter what stage or what size of tumor, is a type 2 T cell response rather than a type 1 T cell response, which you see on the right hand of the slide. These types of T cells are really found rarely. So our group has been developing vaccines to stimulate antigen-specific CD4 T cells for many years. And the reason why we focus on CD4 T cells instead of cytotoxic T cells is because of the data I just showed you. One of the problems, even early in the tumor microenvironment, is that we're already predisposed to have a type 2 immune response. So if you could get vaccine-induced Th1 T cells, as you can see on the left-hand side of the slide, initiating the immune response, you can actually affect the microenvironment by activating antigen-presenting cells that present antigen more effectively, and you can result in multi-antigen immunity or epitope spreading, and even generate a cytotoxic T cell response. Using the HER2/neu protein as kind of our prototype antigen for vaccination, we found that those CD4 T cell epitopes that bound with higher affinity across multiple HLA-DR alleles were more likely to be native epitopes of the protein, meaning if you could generate peptide-specific T cells, those T cells would recognize protein presented endogenously on autologous antigen-presenting cells. So with this data, we created a multi-algorithm protocol by which we could identify promiscuous high-binding epitopes. And with that, we could construct epitope-specific cancer vaccines. But there was a problem when you think about immunizing against common solid tumors. Most of them are not highly mutated. And when you look at what the antigens are that patients with these tumors are recognizing, they're really recognizing aberrantly expressed non-mutated cancer proteins. So one of the problems with immunizing against non-mutated cancer proteins is that they're so close to self that the immune response generated almost predominantly is that type 2 immune response. So we added another layer onto our epitope screening, and that was functional screening. And I'm showing you an example here from IGFBP2, where we created the entire protein of predicted T cell CD4 epitopes, and then we screen the epitopes to see whether they elicited a type 1 or a type 2 response across a population of 40 donors, both cancer patients and volunteer donors. And what we found was the C-terminus domain of the protein had both interferon gamma inducing and IL-10 inducing T cells, whereas the N-terminus of the protein really harbored all the interferon gamma inducing epitope, these type 1 T cell epitopes. And in fact, it was significant that the majority of the type 2 or IL-10 inducing epitopes were in the C-terminus domain of the protein. IGFBP2 is highly homologous between mouse and man, so we created vaccines, and these are in the bottom panel, of the N-terminus, that's 1 to 163, or the C-terminus, that's 164 to 328, DNA vaccines. And we found that if we immunized mice, the C-terminus elicited high amounts of type 2 cytokines, IL-10 and IL-4, in response to IGFBP2, whereas the N-terminus vaccines, very similar to human PBMC, elicited high type 1 immune responses, TNF-alpha and interferon gamma, but very little type 2 responses. So this suggests that it's possible to create Th1 selective and Th2 selective vaccines. But what does this mean in reality? Well, it means that if you took T cells from those 2 vaccines that I showed you in the previous slide, and you expanded them in vivo and infused them into a tumor-bearing animal, you can see, although the C-terminus epitopes were specific for IGFBP2, except in a type 2 fashion, they didn't have any impact on tumor growth. The N-terminus epitopes had a big impact on tumor growth, inhibiting tumor by about 80% after a single T-cell infusion. But for vaccines, when you immunize with the Th1-inducing N-terminus epitopes, you can inhibit tumor growth. When you immunize with the C-terminus Th2 selective epitopes, you have no effect on tumor growth compared to control. But when you mix equal molar amounts of the C-terminus and N-terminus epitopes, the Th2 selective epitopes abrogate the anti-tumor effect of the Th1 epitopes. And we feel this is a major reason why vaccines targeting non-mutated, aberrantly expressed tumor antigens have not had success in the clinic, is that unless you edit out those Th2 epitopes, you'll never get the level of anti-tumor type 1 immunity you need for tumor eradication. So with this in mind, that we can now develop type 1 selective or Th1 selective vaccines, we've really applied this approach to vaccine development. And I'm going to give you 2 examples. One is the creation of a therapeutic vaccine targeting stem cell epithelial to mesenchymal transformation-associated proteins, and the other is a vaccine to actually prevent cancer by intercepting hyperplastic polyps. So our first approach was to try to develop a vaccine against breast cancer stem cells. And we prospectively asked the question, what would be the most appropriate antigens? And we looked for antigens that were non-mutated, upregulated, and overexpressed in breast cancer, associated with epithelial to mesenchymal transformation, which really drives the metastatic potential, associated with cancer stem cells, were an independent poor prognostic indicator in multivariate analysis. And we looked to compose a vaccine of immunogens across multiple stem cell pathways. This is an example of what we found by looking at the immunogenicity of some of these proteins. These are newly diagnosed stage 1 or 2 at the time of primary diagnosis breast cancer. And you can see for 2 antigens, CDH3, CDC25B, both involved with breast cancer stem cells, that we already have a significant antibody response, much higher than what you'd see in age-matched volunteer donors, suggesting again that they've already started a type 2 immune response because you need Th2 to be able to stimulate B cells. We figured out what selective Th1 selective epitopes were from CD105, YB1, SOX2, CDH3, and MDM2, and encoded these into a multi-antigen polyepitope Th1 selective vaccine we called StemVac. Now, much like IGF-BP2, these proteins are highly homologous between mouse and man. So we immunized mice with StemVac and demonstrated that we were able to generate high levels of interferon gamma secreting T cells specific for these antigens. You see these in gray bars in the upper left-hand panel compared to control. When you look at IL-10 secretion from these antigens, we don't see any after StemVac immunization. When you look down to the lower panels, we have high levels of granzyme B release directed against each of these antigens compared to control, demonstrating CD8 T cells with lytic potential were initiated. And here on the right-hand lower panel, you can see evidence of lytic activity against M6, a cell line in a transgenic model of triple-negative breast cancer. We take that same transgenic model of triple-negative breast cancer, the M6 cell line derived from a spontaneous tumor. We vaccinate the animals with StemVac and then give them a tumor challenge, and this is in the left-hand panel. You can see immunization with StemVac almost completely suppresses tumor growth compared to the vector alone plus adjuvant. When we take tumors from the animals at about 30 days, when you see this big difference in tumor growth, and we look at the TIL in the tumor, you can see we've got a significant decrease in SCA1 positive cells, which are stem cells in mice in the StemVac immunized animals, a marked increase in CD8 T cells, and when you look at antigen expanded TIL, granzyme B release, ICOS expression, CD69, T-BET, a marker of Th1. So we've been able to generate a very type 1 immune environment in the tumor. When you look at a luminal B model, this is a transgenic animal model where the animals got immunized at about 18 weeks with StemVac. We can protect the development of tumor in animals, almost 50% of animals at over a year compared to controls. And since StemVac, the EMT signature is found in multiple tumors, here you can see that in a lung cancer model, StemVac also shows significant activity. So we took StemVac into a phase 1 dose escalation study. These are the parameters in stage 3 or stage 4 hormone receptor positive or triple negative breast cancer. Patients had a complete response or stable bone-only disease. We gave 3 doses of StemVac, 3 vaccines 1 month apart, and boosters in 3 and 9 months. We found that the immunogenicity of StemVac was dose-dependent, with the intermediate dose of StemVac really being the most immunogenic. In fact, the fold change in immune response post-vaccination was a median of 500-fold. The immunization was safe. We did not see any signs of autoimmunity, and there was also no increase in antigen-specific IL-10 secretion, T regulatory cells, or PD-1 expression on the T cells. In fact, the levels of immunity achieved with StemVac were very similar to levels of immunity achieved with mutated antigen or neoantigen vaccines. And another finding we found was looking at the boosters, which again we gave at 3 and 6 months after the priming vaccines. We found that after the prime, the average number of antigens that patients responded to were about 2. But after the 2 boosters, especially in arm 2, the majority of patients had significant levels of immunity to 4 or even 5 antigens in the vaccine, showing that there wasn't antigen competition, and this drives the level of Th1 responses even further. And so you can see the clinical application of StemVac could really be applied to many tumors. Pancreatic cancer, prostate cancer, colon cancer, liver cancer. Many tumors are associated with a stemness signature. So I'd like to end about a vaccine that we're developing, looking at targeting cancer initiation proteins with the thought that we could potentially prevent the development of cancer. And we asked the question, what would be the antigens that we would target with a Th1 selective vaccine? So we looked at genes that were highly expressed in both polyps and colon cancer. And then we asked the question, if we knock those genes out, what would happen to the cell? And we prioritized those genes that when you knock them out had a significant functional effect on the colon cancer cell line, either significantly reducing proliferation or inducing apoptosis. And then we looked at whether the proteins encoded by those genes stimulated immune responses. And here again, you can see colorectal cancer patients versus controls with very significant levels of antibody immunity. Again, a primary Th2 response already found in patients with the cancer. And here you can see some of the antigens that we were evaluating. Again, CDC25B, COX-2 came up in the panel, Fashion-1, RKS1, and again, with very significant elevations of antibodies in colorectal cancer patients versus age-matched volunteer controls. So we created Th1 selective single antigen epitope-based vaccines to CDC25B, COX-2, Fashion-1, and RKS1. And we looked at spontaneous tumors in AOM-treated mice, where the mice develop polyps that progress to invasive carcinomas. And you can see, compared to animals immunized with adjuvant alone, in the left-hand panel, we were able to significantly inhibit the development of polyps in CDC25B and COX-2 immunized animals, not really so much in RKS immunized animals, and some effect in Fashion immunized animals. But again, in the right-hand side of the slide, you can see for CDC25B and COX-2, we had a large influx of CD8 T cells into the polyps that developed in these animals. And when we used a tumor cell line derived from the AOM and did a similar experiment as I showed you in the triple-negative breast cancer animals, where we immunized first and then challenged with the tumor cell line, and then did cell depletion studies, we found that the anti-tumor effect of both the COX-2 vaccine and the CDC25 vaccine was completely due to the CD8 T cells that were elicited with the vaccination, that epitope spreading. If you abrogated the CD8 T cells, you absolutely abrogated the anti-tumor effect of vaccination. So we looked at another model. This is the APC-Min model. And we thought, if we were going to take this into a prevention strategy, let's say in high-risk populations, such as those who have FAP that are initiated by the APC gene, we need to really give the vaccination in combination with naproxen or some COX-2 inhibitor or COX-1 inhibitor like celecoxib. And so we just tested in our model in APC-Min mice to document that naproxen inhibited tumor growth, has been shown multiple times before. But what we wanted to do was collect tumors from the animals and get a baseline of what naproxen was doing alone immunologically before we added on vaccine. And what we found was very interesting, that naproxen actually significantly reduced PD-L1 expression on the surface of the polyps as compared to control. And here you see this in the upper panel, and this was done in a dose-dependent fashion. And in fact, PD-L1 suppression by naproxen was associated with the anti-tumor response. For those animals that did not suppress PD-L1 with naproxen, those were the animals that were more likely to have tumors. And you can see the result was very highly effective. So we asked the question, what was mediating this effect on PD-L1? Was it COX-1? Was it COX-2? And naproxen allowed us to address that question because it's both a COX-1 and COX-2 inhibitor. And we found that when we knocked out COX-1, nothing happened to PD-L1 expression. But when we knocked out COX-2, PD-L1 expression was remarkably reduced. So this is an immunologic effect now for COX-2 inhibitors. COX-2 regulates PD-L1 expression not only in APCs, but also in the tumor itself. So we went on to the APC-Min, 20 animals per group, with a 3-antigen vaccine, CDC25B, COX-2, EGFR, all Th1 selective epitopes. And here you can see adjuvant alone, very similar to control, which I don't have on the slide. Naproxen, which significantly suppresses polyp formation. The vaccine, which also significantly suppresses polyp formation. Again, the results with the vaccine are much more heterogeneous. But the vaccine and naproxen, given concurrently, almost totally suppressed the development of polyps in these transgenic mice. And when you looked at vaccine-induced antigen-specific Th1 cells, you can see naproxen does not stimulate immunity to CDC25B, COX2, or EGFR, whereas the vaccine does. It causes, compared to control, very significant interferon gamma secreting T cells. But the combination of vaccine and naproxen really increased the level of antigen-specific T cells much higher than vaccine alone. So naproxen almost acts as a systemic adjuvant for the development of vaccine-induced Th1 cells. You can see that the vaccine-induced Th1 cells, the higher your systemic immune response is in this top right-hand panel, the better you are at controlling polyp growth. The p-value is 0.04. And similar to what I showed before, the higher the levels of CD8 T cells you have in the tumor, the better, again, you control polyp growth. With those patients with the highest number of T cells in the tumor having the lowest number of polyps overall, with a very significant p-value less than 0.0001. And so we're moving ahead to potentially test this vaccine in a high-risk population. And there are populations that are really looking for different strategies to try to prevent the development of colon cancer. And we were really struck by a very interesting study by Joel Samatter that was published in JAMA, where he went to a group of patients with familial adenomatous polyposis, where they'd really had their colons removed, but now the polyps are even developing in the small intestine. And he treated patients with Sulindac, a COX2 inhibitor, and erlotinib, which is an EGFR inhibitor. And what they found was they were able to significantly suppress the development of polyps in both these patient populations. We think this is a great use of our vaccine, generating immune responses against COX2, EGFR, and CDC25B for a few reasons. Vaccines have a tendency to cause less side effects. Vaccines can be given a very short course. Immunologic memory is generated, and there's no need for chronic drugging of a patient over an extended period of time. And finally, with that immunologic memory, the immune responses are ongoing and ongoing as long as antigen is in the area. So we think a vaccine approach instead of a drug approach would almost be like having the immune system giving chronic Sulindac and erlotinib to these patients without, again, having to give drugs on a daily basis. So these are two examples of the promise of vaccines for cancer. One used in the treatment of cancer, or even the prevention of disease relapse in terms of the stem cell vaccine. The other, really looking at the primary prevention of cancer through cancer interception. And when you think about what vaccines have done for human health, really in the last 100 years, most of the infectious diseases that used to kill us 100 years ago are now almost fully contained by vaccination. And with the advent of better vaccine technologies, a better understanding of what antigens are available for us to target in cancer vaccines, and the formation of multi-antigen vaccines, and most importantly now, our ability to create either selective Th1 or selective Th2 responses, I think vaccines may become a reality for cancer in the very near future. And with that, I would like to end by by thanking my colleagues at the UW Medicine Cancer Vaccine Institute in Seattle, especially Denise Cecil, Jennifer Childs, Andrew Cavalier, Will Gwynn, Doreen Higgins, and our mouse modeling core and immune monitoring laboratory through which we run all our clinical trials. Thank you very much.
Thank you very much, ma'am, for this very informative talk. I would like to invite our lead discussant, Dr. T. Raja sir, who is Director and Senior Consultant of Medical Oncologist from Apollo Hospitals, Chennai. Over to you, sir.
Thank you, organizers, for inviting me here. Thank you, Dr. Jyoti, for this extraordinary opportunity. And it was such a fantastic experience to hear Professor Nora Disis. And Madam, I must say that that was a fascinating lecture. I did review your work over the past 2 decades in University of Washington. Such dedicated and such passionate work, and we really convey our congratulations to you on what you have done. And I have borrowed some slides for your own previous lectures, and please pardon me for asking some very naive undergraduate level questioning to you. And hopefully I want to take your expertise to our people. That's my idea. And to ask you, this is from your own work and your own lectures in several forums. You have often told that why it was difficult to be successful with vaccines with the malignancies, because somehow they are able to escape the entire mechanism of how immune cells take care of anything and everything. And it could be either because of what happens with the inefficiency of the antigen presenting cells, and so on and so forth. And you have also shown that by combining so many methods, and also particularly acting on the dendritic cells, you can do something to make the cancer look more dangerous, and therefore finally recognizable, and avert the immune silence. And so where is this all? And now with all these things, and with your presentation of new antigens, is the dendritic cell approach is done and over? Has it not made any progress? Can you comment on that?
Sure. I think that there has been a very big advance in vaccine technologies, and some of the approaches, such as using dendritic cells to deliver antigen, or different types of adjuvant systems, have generated immunity, but they haven't generated immunity at the levels that, let's say, you would see in an active viral infection. I think part of the reason why we haven't seen high levels of type 1 T cells being generated is that for most common solid tumors, they're not highly mutated. So mutation-based vaccines are going to be difficult. And when you immunize with non-mutated self-proteins, several studies have demonstrated that there are epitopes within those self-proteins that actually elicit T regulatory cells. I think for us, the big breakthrough is not only different vaccine technologies, such as we use DNA, other people use mRNA, which is a way to give that danger signal to the immune system, but removing those epitopes which cause that self-regulatory response has really allowed kind of an unleashed type 1 immune response. So we are seeing these vaccines generating levels of immunity that you would see against a viral infection. And so, when you talk about giving a DNA vaccine and stimulating toll-like receptors, that gives a vaccinated response because you're stimulating dendritic cells, skin dendritic cells with that vaccine.
Yeah, staying with dendritic cells, we now, your own work and many others have shown that, again, they are not, single set, they are multiple subsets of dendritic cells and so on and so forth. Has there been progress in finally kind of, pushing the dendritic cells? These are the dendritic cells based vaccines. And has there been enough success in finally making the in your own words, you have called these innate immunity as dumb cells. And has there been success in finally converting these players into more potent killers? Has there been enough success or not?
I think there has been some success. I think where the field is going today is that people are looking at trying to stimulate the dendritic cells in situ, rather than removing them ex vivo, loading them with antigen, and infusing them into the patient. And the reason why is the dendritic cells don't migrate in vivo once you infuse them. People have labeled them, and where you inject them, they pretty much sit there. But we found that if you can activate the dendritic cell at the site of vaccination, that dendritic cell will migrate to the draining lymph nodes and start the immune response. So I think many of the new vaccine technologies you're seeing now, either using RNA or DNA or encoding a vector with cytokines that activate local DCs, I think we're beginning to see much higher immunity being generated, and hopefully that will translate into improved clinical outcome.
Thank you, madam. So, you have presented your work on the neoantigen, and that's, finally, it is how to recognize the difference in the cancer cells and neoantigens. You have talked about neoantigen-based cancer vaccines, be it RNA, DNA, or whatever. That seems to be the real cutting-edge modern. And in the chat box also, you have answered that the response to the neoantigen versus innate antigens and all that. But my question is, the tumor cells have got so many different, even among neoantigens, and this is your own work. How do you really select out which neoantigens are the best to produce immunity against? Is that, beyond labs, it's now moved into the artificial intelligence domain. How do you, at the lab level, choose which neoantigens to go about?
Well, I think if you're focusing on neoantigens, either mutations or splice variants, you have to choose those that are truncal. So they're found in the majority of cells, and they're very important in maintaining the malignant phenotype. Too often, if you're just trying to choose mutations, let's say based on sequencing a circulating tumor cell, for example, you're going to end up with mutations that are out in the branches of the tree. And those mutations, you can eliminate cells that express those mutations, but that may not do anything much for tumor growth. And again, for the tumors that we focus on, breast, ovarian, colon, they're just not highly mutated tumors. And that's why we had to figure out how to make non-mutated self-proteins more immunogenic. And then we came upon the fact that we could identify these epitopes that, for whatever reason, probably because of their rarity within the self-protein, don't get presented. They're lower avidity epitopes compared to the Th2 selective epitopes, and there's many less of them.
Thank you, Professor. But you have shown extraordinary work in HER2 directed vaccines, and this is your own work on how a HER2 extensive disease can be treated. And you have also several times argued that HER2 is ubiquitously present, commonly present antigen. And how did you make this HER2 more antigenic? And also your work on against the stem cells. how did you convert these, non-mutated, aberrantly expressed antigens into a new antigen, like where the cells can recognize and produce immune against? And one question from the chat box, from Dr. Sandeep is that when you use the stem vac against the cancer stem cells, how do you prevent it from acting against the normal stem cells? So I think both are related. That's why I'm asking this question.
Sure. One of the things about aberrantly expressed, highly overexpressed proteins, and this work was published almost 20 years ago in both the cancer and autoimmune literature, is that the peptide repertoire display that is present in the MHC when a self-protein is highly overexpressed is a different peptide repertoire display than when the protein is expressed at basal levels. The marked upregulation of the protein unmasks subdominant epitopes that now, because there's so much of the protein, make it into the MHC in high enough levels to stimulate the immune response. So this aberrant upregulation of a protein in cancer can make the immune response truly cancer specific, because those peptides aren't present when the protein is expressed at normal levels. So that's number one. And there has been a meta-analysis of over 600 patients immunized with mostly non-mutated tumor antigen vaccines over a period of about 20 years. And there has not been significant toxicity and little autoimmune toxicity. So how can we make these neoantigens? By removing those epitopes from the vaccine that stimulate regulatory cells. You cannot use a whole protein non-mutated vaccine. They have to be epitope edited to remove out those epitopes that are causing the Th2 responses. Unless you do that, the vaccine is not going to be successful.
Thank you, Professor. This is my last question. So these are the list of possible targets under clinical, according to the American Cancer Society. Among these, some of these are your own work. As a clinician, can you give us a sense which one is closer to the clinic, beyond phase 2 or phase 3, among the entire list that is presented here? And also there was a question about the TCR, V beta reporter and all from Dr. Subeda and Dr. Sharmila. You answered that, but for me as a clinician, which one is nearer to the clinic, and what do we expect at a phase 2 or phase 3 level? Can you tell us sense of what is coming up?
I think much like the infectious disease vaccines we get, multi-antigen vaccines are what's needed. And those antigens that have significant biologic relevance to driving tumor growth are going to be those antigens that are put into those multi-antigen vaccines. I think if you immunize with only a single antigen, you may be able to get an overall survival benefit, as we've seen with some vaccines. But in terms of being able to eradicate the cancer, you're going to get immune pressure generating antigen negative variants rather than generating a very high T cell response from multiple antigens that will really jumpstart the endogenous immune response to wipe out cancer.
Thank you, Professor, for answering all my questions. And it was such a privilege to even interact with you. Over to the organizers. Thank you so much.
So thank you very much, Dr. D'Souza. Indeed, it was an exceptional talk as always, and I always cherish interacting with you in our prior meetings as well. And I hope to host you in future in person in India. And thank you very much, Dr. Raza, for wonderfully taking this discussion through. Thank you, chairpersons, for your presence during the session and completing the session on time. So from here, I will hand over to Rekha again for further proceedings. Thank you very much.
Thank you very much. Good night.
So now I would like to invite our next chairpersons, Dr. Tapan Sekia sir, who is Director and Head Department of Medical Oncology at Prince Ali Khan Hospital, Mumbai, and Dr. Vikram Matthews sir, Executive Member of IOSI, Associate Director, Professor, Department of Hematology. Over to Dr. Tapan sir for session introduction.
Good morning to you all. It's a privilege to be here, and I'm thankful to the organizers for engaging me in this session. Today's topic is cellular therapy in multiple myeloma. Malignant plasma cells have a fascinating biology. All symptomatic myeloma will have a precursor, MGUS. But all MGUS will not proceed to symptomatic myeloma. Apparently, it depends on the genomic instability or stability of the malignant plasma cells and possibly of the microenvironment. These malignant plasma cells are therapeutically responsive to a host of agents, namely glucocorticoids, chemotherapy drugs in a small dose or a massive dose, cell mods, proteasome inhibitors, small molecules are selinexor, HDAC inhibitors, and our monoclonal antibodies. However, eradication of these malignant plasma cells is not easy with the available treatment. That's why we need more. In these days of cellular therapy, there is a proof of principle that cellular therapy works. We know from allergenic stem cell transplantations and donor lymphocyte infusions. But LOSCT is not a safe procedure and cannot be offered to each and everyone. In this decade of immunotherapy, particularly the CAR-T therapy,
Hello, I request Vikram sir to invite our keynote speaker, Dr. Neena Shah.
Thank you, Dr. Tapan Sekia. I think we lost you in between there. But it's my privilege to, Dr. Tapan sir, are you there? Do you want to finish up? We lost you in between.
I think
I'm
some
here.
technical glitch here.
Okay.
I don't know. I got unmuted. That's okay. We have a speaker. I don't have. Vikram, please go ahead.
Please go ahead, sir.
We have to keep the time.
Okay, sir. So it's my privilege to invite the keynote speaker. It's truly a privilege to have with us Professor Neena Shah to discuss with us on the role of cellular therapies in the management of multiple myeloma. Professor Shah is a professor of clinical medicine, division of hematology and oncology at University of California, San Francisco. Many of us are aware of all the work she has done both in the area of myeloma and in vaccine therapies. She's also interested in outcome research for myeloma patients undergoing autologous transplantation and has led randomized trials to determine the impact of stem cell dose on symptoms in this patient population. She has obviously published extensively. She's heavily involved in myeloma research community and is very much involved in making many of the myeloma transplant practice guidelines for the American Society of Cell and Cellular Therapy. And she also works as the co-chair for the plasma cell disorders of the adult solid tumors working committee of the CIBMTR and is a member of the American Society of Hematology Scientific Committee on Plasma Cell Neoplasia. Over to you, Professor Shah, to take the topic forward.
Thank you. And if it's okay with you, I'll start sharing my screen.
Please do.
Okay, thank you so much for having me today. It's really a pleasure, and I'm sorry we can't be in person. That would be best. But I'm really excited to talk to you about emerging role for cellular therapy for multiple myeloma. As mentioned, I'm at UCSF, but funnily enough, I'm actually on the East Coast visiting my mom tonight. So it's a midnight here, but morning for you guys. All right. So for anybody who is interested in knowing more about cellular therapy for multiple myeloma, you can't not know the target, which is B-cell maturation antigen, this is usually the target for our cellular therapies. It's a member of the TNF receptor family, and it's associated and involved with plasma cell survival. What's really important about it is it's very specifically expressed on the surface of plasmablasts and differentiated plasma cells, which makes it a very good target for effective cellular therapy like BCMA-directed CAR T-cell therapy. The first of this was, well, not the first, but the most, I think, famous, the way to put it on the map, was BB2121 ide-cel, and this was actually studied in a phase 1 study, just a phase 1 study where the higher doses showed a median progression-free survival of 11.8 months, which is really unprecedented, and people who had MRD negative disease had a median PFS of 17.7 months. And this updated data was shown at ASH this past year, and the median overall survival was 34 months. For anyone who's treated myeloma patients in their 7th or 8th line of treatment, you know this is really, really impressive data. And because of this, the pivotal KARMA study was done. This is a phase 2 single-arm study looking at patients with relapsed refractory multiple myeloma, at least 3 prior lines of therapy, all exposed to PI, IMiD, and CD38 antibody. And those patients were enrolled on this trial. They underwent leukapheresis, as you can see, and then had the option for bridging chemotherapy, and then got their lymphodepleting therapy with fludarabine, cyclophosphamide, and then CAR T infusion. There were 128 patients infused, and overall they were very sick, with a median prior line of therapy of 6. So very, very heavily pretreated myeloma patients. It was pretty safe, although CRS occurred in 84% of patients. This tended to be low grade, grade 1 or 2, and it tended to be treatable by tocilizumab or steroids. Neurotoxicity was pretty low level, 18%, and again, generally grade 1 or 2. So actually the safety of this was pretty good. On the right-hand side, you can see the overall response rate for all doses looked at was 73%. Now, I know it's a little bit confusing that this is a phase 2 trial, but they did have different dosing cohorts just to see how they would do, and they ended up going with a 450 dose, and here in this higher dose you can see the overall response rate was 82%, and you can see the median progression-free survival for all of the patients was 8.8 months, but if you look on the left-hand side here, you can see for the patients who got the 450 dose, their median PFS is here at the top left green curve, around 1 year. Now, if you got into a complete response, the median PFS was actually much better, of 20 months, which again is very unprecedented for patients with multiple myeloma. This data was updated this past ASH, looking at the overall survival of these particular myeloma patients. At ASCO, I should say. And the median overall survival was about 2 years. And this was true whether patients only received 3 lines or if they received more than 3 lines, which is important for the FDA indication. What's interesting is it's hard to do this data as a randomized control trial. Like, nobody's going to enroll their patients on this versus placebo, right? So you had to do a matched analysis, matched comparative analysis with Mammoth data. The Mammoth data is a data set of patients in the U.S. who were treated with anti-CD38 antibody at some point, and then they were analyzed to see what happened at their next treatment. And you can see when you compare the ide-cel population in the blue or light blue versus the Mammoth population, either for overall survival or progression-free survival, the ide-cel population way outperforms the Mammoth population, which would be considered conventional care, even though we can't really do a randomized controlled trial. One of the things that I think is really important is quality of life. And remember, CAR T-cell therapy is 1 infusion, so it's important to know how people do. And in fact, even despite 1 infusion, people actually had decrease in their fatigue and pain scores and increase in their physical functioning and global health quality of life scores for several months, including 9, 12, and 15 months out from that therapy, which is actually very interesting because it's a one-time treatment and they're still doing well. In addition, when you talk about secondary subscales on the EORTC QLQ, you can see that role functioning, emotional functioning, and social functioning, among others, these are what I call the human aspects of being a patient. These actually were higher than a minimally important difference and maintained this several months out, even despite it being just one treatment. I think this is really important because if we think about treatments and cost, we have to think about quality of life. And so I found this data very encouraging. And so because ide-cel had safety, efficacy, a good progression-free survival, likely improvement of PFS over conventional care per the matched analysis comparison, and quality of life improvement, it became the first BCMA-directed T-cell therapy approved in the United States for patients with relapsed refractory multiple myeloma. But it's not the only product that's going to be FDA approved. The cilta-cel product, which is made by Janssen, is also showing very nice data from their study CARTITUDE-1. Now, the difference between this BCMA CAR T-cell and ide-cel is that it has two specific binding domains on the extracellular domain. You can see here it binds two different epitopes of BCMA, and this may explain some of the differences that we see in function and toxicity. These patients were also very heavily pretreated, median prior lines of 6, and many of them were triple and penta refractory, having been exposed to all of the novel agents. So what I find interesting about this data is the overall response rate. 98% of people responded. That's a really, really high response rate for this very heavily pretreated population, and they have very deep responses. For example, 95% with VGPR or better. I mean, you just don't see this data in phase 1. Now we know from Dr. Usmani's presentation at ASCO that the median duration of response appears to be 22 months so far. Maybe it'll be more, depending on what the data shows. And this is really unprecedented to have almost 2 years of response when you only have a one-time infusion. So again, I think this is game-changing for cellular therapy in myeloma. We don't have the PFS yet, but at the 18-month data cut, 66% of patients were still in response. So that's very encouraging. Now, of course, there's no good without any bad, and it turns out almost all patients get CRS. It usually tends to be low grade, but what's interesting is the signal of neurotoxicities that you can see here on this table. 20.6% of patients had neurotoxicity, but only 16.5% had true ICANS, which is the immune effector cell-related neurotoxicity that manifests as confusion. However, another 12.5% of patients had sort of an alternate neurotoxicity, which could be polyneuropathy or cognitive motor dysfunction. And one patient did pass away of this, and this had not resolved. And because of that, there was concern about why this might be. Dr. Usmani very nicely pointed out that there have been no additional safety concerns for neurotoxicity in the CARTITUDE program, and that it might be related to disease burden. So it's something we need to think about in the real world. So when we go to any of these conferences, we talk about all the various CAR T-cell therapies, and you can see here I call it the House of CARs, and the first three there are your general BCMA-directed CAR T-cell therapy, and just look at this data, somewhere between 70 and 98% response rate. Really, really impressive, with manageable cytokine release syndrome, and we know some durable responses which need to be taken into consideration, especially for myeloma patients who are on therapy forever. Now, we do have some alternate types of cell therapy and ways to improve upon this, and I'll just quickly go through some of these examples in the interest of time. The Poseida product actually used a transposon system, not a retrovirus or lentivirus system, to increase the effector memory and effector memory stem-like phenotype in the particular T-cell population. This also allows it with its engineering to have a very small centyrin, so it's not a quite extracellular domain that's like an antibody, but it's a centyrin peptide extracellular domain, and this allows a lot of genetic flexibility in engineering, and you can see there can be a safety switch, the CAR molecule, a selection gene, and this allows the investigators to actually select for a more T stem cell-like memory phenotype in the actual product. So far, all we know is that the overall response rate in their phase 1 study looks to be about 57%, but it may be more, as you can see here with the blue versus the red, with their new nanoplasmid manufacturer. So we are looking forward to seeing more data from Poseida. It seems to be pretty safe with very low CRS and may be able to be infused as an outpatient. Another group that's looking at increasing the T stem cell memory-like phenotype is the Bluebird group with BB21217. Now, this is the same construct as BB2121, which is ide-cel, but it's cultured in the presence of a PI3 kinase inhibitor, which allows more memory-like cells to grow, as you can see, by increased CCR7, as well as increased CD27 and decreased CD57 here in the flow. And what you can see here from their phase 1 study is that their overall response rate appears to be around 68%, but in the higher doses is 73%, with very nice MRD negativity data. And patients who are in at least CR have MRD negativity, which is actually very encouraging. Now, if you look at the duration of response, which is important here, because remember, the point of this product is to increase the persistence of T cells. So this would speak to the duration of response. So far, the data looks good, a median duration of 17 months, and this seems to be better in the higher doses. What I found really interesting is that when they looked at the correlative data, it looks like patients with a higher proportion of memory-like T cells in the final drug product had better T cell expansion, and that actually was associated with less disease progression. So here their hypothesis is just starting to become true, that culturing these cells allows more T stem cell like memory cells to be there, and that in vivo this makes a difference, allowing for a greater duration of response or potentially increased in vivo expansion. And so I look forward to additional correlative data from this group. One thing that I think is really interesting is the Allergenic T cell platform, and this was looked at from the Allogene group Allo715. Now, when you have allogeneic CAR T cells, it means that there's going to be an off-the-shelf product, and you have to account for graft versus host disease, and so they take out the T cell receptor and engineer in the CAR. So the T cells don't actually attack the host because the T cell receptor is missing. In addition, they have taken out the CD52, and that allows the investigators to actually give not only fludarabine and cyclophosphamide, but also an anti-CD52 antibody to have really deep lymphodepletion so that these allo cells will come in and not be rejected. This data was presented by Dr. Malignant at last year's ASH with the Allo715 construct, and you can see here that now, it's a phase 1, so we don't know everything, but at these higher doses, for example, in their fludarabine, cyclophosphamide, and Allo647 depletion cohort of 300 million cells, they actually got 60% overall response rate, which I think is very interesting because for allo CAR T, the bar can be a little bit lower because there's no apheresis and fewer logistics. Here you can see that there was actually no GVHD or ICANS, which was very interesting, and we think it's going to be nice as far as taking this to an allergy. Interesting thing that was presented this past year is the fast CAR. This actually allows for CARs to be generated pretty quickly, but more importantly, they actually had a dual BCMA CD19 targeting CAR, and the reason for this would be to try to get at the sort of myeloma progenitor cell. So they were able to show a very nice overall response rate of 95%. But I just want to say that even though this is the response rate, the point of this particular product is to really get at the myeloma progenitor cell. So the real data is going to be in the duration of response, not the overall response rate, although this does look very promising. And we're looking forward to having more of this data available this year. Another thing that we think about with CAR T cells finally is maybe we shouldn't be waiting till lines 6 and 7 to use them, and maybe we should use them earlier. And that's what the CARTITUDE-2 study is doing with cilta-cel. Cohort A was presented this past year at ASCO, and this is in patients with 1 to 3 prior lines of therapy, not 3 or more. And you can see here for these patients, the overall response rate has been very nice, also 95%. But truly, the value of this study is to understand the progression-free survival. Is it going to get beyond 12 months like with Apollo, or is it going to get beyond 28 months like with Candor? And this will allow us to understand if doing CAR T earlier, where patients' T cells are less beat up, actually allows for a greater percentage of overall response rate and duration of response, which is what we're really interested in. So now ide-cel has arrived. What are you going to do? I was compare this to having like a new baby in the house. Well, what are we going to do with this new baby? But that's exactly what we feel like, because the label ended up being a little bit more strict than the actual clinical trial. So the clinical trial allowed patients with at least 3 prior lines of therapy, but this now is asking for at least 4 prior lines of therapy. But in the US, our patients are getting VRD, transplant, len maintenance, that's all one line. And then they may get Darapom-Dex, then maybe Carcidex, and then by that time you get to the 4th line and you'll be doing things like cyclophosphamide, bendamustine. And of course, I always call myself a millennial, which means I like to use all these new drugs up front. If I'm using KRD or Dara-VRD up front, this could make it more challenging to get to line number 5. Of course, you can always trick the insurance company and say, well, we gave single-engine Dex and she didn't respond, so that might be another way to trick the company. But I do think it's going to be interesting how we're going to use this information and decide between CAR-T and T-cell engager. With that, I want to say thank you to the whole audience and also to the entire organization for allowing me to participate. I really wish that we could be here in person. This is our team at University of California, San Francisco. This is just our myeloma team. This is our group here in the center. Of course, we're very COVID compliant. And on the bottom right, we always have our Cinco de Myeloma party, which we love having. And we'd love to have anyone who's visiting San Francisco. Hopefully, the world will open up and you can come see us in person. Thank you so much.
Thank you, Dr. Shah, for that very informative talk. Now I invite my friend, Professor Bausa Bagal, to moderate the sessions. Dr. Bausa, please.
Yeah, thank you, sir. And thank you, organizers, for this opportunity to moderate this question and answer session. And it was really nice to listen to Dr. Nina. We hear her from her quite a lot in the meetings and on Twitter, and we know how active she is in the research. And it is really dream come true. So this year we had approval for the CAR-T for myeloma, and I think this is a very apt time to discuss the advances. So meanwhile, I will get my slides. I'm going to cover a few points which will be helpful us to keep our discussion on track. And so the first thing is when we want to use cellular therapies, let's forget about the antibodies and drug conjugates and bites, etc. But we seem to have mainly 2 options currently available to us. One is CAR-Ts and NK CAR. And Dr. Nina, your work in NK CAR, your early work in NK CAR, I went through it. So what's your thought on this? How are these 2 placed in the treatment for myeloma?
You know, I'm really interested to see what's going to happen with NK CAR, because it's going to be an allergenic off-the-shelf platform. So, for example, Fate Therapeutics has an engineered CAR cell against BCMA, and that's going to allow us to do off-the-shelf NK. Now, the good thing about NK cells is you don't have to over-engineer them because they don't cause graft versus host disease. But the bad thing is that they may not stick around for long. We don't know that. So I think if they do their work within the first month, then they'll be a competitor for CAR T cells, and they will be an off-the-shelf a product, which is very, very attractive to places that don't have access to quick apheresis.
Yeah, so that's nice to know about having. I think they are more appealing for situations where resources are not there to get these engineered cards, and
right.
Probably that's one thing to look in our setup as well. The next question to come is about the target. So we have so many target, and BCMA seems to be a very perfect target. So it is universally expressed, very less or almost no expression outside myeloma cells. So we are still looking for targets. So what's your thought process behind? Are we seeing really some promising targets, and do you expect some change in activity with these targets?
Yeah, I mean, it's a great point to bring up. I want to say a couple of things. One, BCMA is a great target, but I don't think it's the only target. And I think it's, as I mentioned, it's expressed on these differentiated plasma cells. But truly what's going on with myeloma, in my opinion, is that there's some progenitor cell that we don't know the exact proteins on it. And that's one of the reasons why the FAST-CAR program has been developed for CD19. But other things that have been looked at are SLAMF7, which is the target for the Selectus AlloCAR program. So they've been looking at SLAMF7 as a target. That can be very potent because SLAMF7 is on other cells as well. So that can cause a lot of immunosuppression. And then GPRC5D is the new target kind of to watch, because a lot of patients are being treated with the GPRC5D cells. cells, specific cells, and those patients have had previous BCMA exposure. I believe 12% of patients in their study had this. That was for the BiTE, but we'll see with the CAR T, which is going to hopefully be presented soon, that with GPRC5D directed CAR T cell therapy, it might be able to rescue the BCMA failures.
Okay, I think it's important to have targets because probably we'll be able to sequentially use them one after another. One question to targeting BCMA with CAR T, if someone has, for example, received a BCMA BiTE earlier, so do you think there is less responses or it is still active?
I think actually changing up anti-BCMA therapies is okay because what we know from some of the data that was seen at EHA 2 years ago is that patients who progress, for example, on ide-cel, they don't lose BCMA. They still have BCMA. So they just need a different BCMA product to try to work on their disease.
Okay. And the CD19 targeting seems very interesting and rational. So do you see a positive signal there? Do you think are we seeing a long-lasting responses or it is too early to draw any conclusions?
Definitely too early, but I will say that we haven't seen anything exciting as far as response when other people have tried it. So the Penn group has tried CD19 CAR T also for myeloma with not too much raging success, and so I think that we have what data we do have has not been as promising. The FastCAR is interesting because they're doing dual targeting, so maybe that's the way to do it. Maybe you can't just do one or the other, but you actually have to get them both at the same time in the same cell, and that could be something that'll help. And we'll see a little bit more data, hopefully from them, hopefully from ASH this year.
Yeah. So coming to dual targeting, so we have a very good data with. CAR-T2, it is encouraging to see that. So do you think the field is moving in kind of dual epitope or dual targeting with myeloma CAR given the limited duration of responses with single targets?
I think the field is moving to more complicated CAR-T engineering, and that does involve more intelligent target discovery. Like we can't be just doing BCMA forever, right? That's not going to work. And so I think it's good to have additional targets on these CARs. And I know, for example, when Dr. Eric Smith, who's now at Dana-Farber, but he was at Memorial Sloan Kettering, when he was working there before, he did have a CAR that was against, for example, BCMA and GPRC5D. So that would really be pushing against a lot of these cells, these myeloma cells, and you want to get as deep response as possible.
Yeah. So I think we are going to see some advances there also. Coming to challenges, so there seems to be a relapse, which is kind of, though we are nearly touching 2 years of PFS with the recent data, but they tend to fail. So what's the common way of failure post CAR-T therapy vis-a-vis, for example, CD19 in lymphoma? So how common is downregulation and maybe T-cell loss?
So it does happen, and Dr. Munshi just published on this for one of his patients that had received a BB212 product, but it's not uniform. It's kind of not like CD19. I think these cells get to grow and grow. Once their progenitor takes off, they start growing. But by the time that happens, it's been a year that they've already had CAR T, and so they have that response. But then once they grow the cells now they express BCMA, they can be attacked by another BCMA directed therapy. The only thing is they can't get retreatment with the CAR T because now their immune system has memory against that CAR T cell therapy. Even though it was autologous, it could have sprung some, it's kind of altered, right? Because it's got that extracellular domain. And so that's why the immune system sees it and rejects it. And so that's why I think it's good to target two things at once and try to get rid of as much tumor burden as possible at the beginning.
Yeah. So another interesting concept was the BCMA upregulation by gamma secretase inhibition. So your comment on that, Ms. Do you think the strategy is working? Is it?
Well, the Fred Hutch published on this. They did have like 100% response rate with their GSI plus CAR T therapy. Now, a couple of those patients, including one of ours, had recent CAR T therapy of another kind and had failed that, but they did respond to this particular CAR T therapy. So it does make the beg the question of maybe sometimes maybe if there's failure, it is because the patients don't express so much BCMA or not enough for the CAR T cells. That I think was interesting, but we'll see what the updated data shows.
Yeah. So I think another factor as opposed to lymphoma patient is these patients are often elderly and tolerance is an issue. So
Huge.
So vis-a-vis those CD19 therapies, what's your take on the CRS and ICANS with so let's say BCMA targeting CAR?
I have to tell you, so far, and maybe it's just my experience, I think the CRS and neurotoxicity is way better and easier for BCMA CAR T cell therapy versus what we've seen with Yescarta, for example, which is clinically available in the US for lymphoma CAR T. So I think there's some differences in quality. For sure, myeloma is a different disease than, for example, ALL. So that blood-brain barrier in ALL is just, it's not as as tight as the myeloma patients. So I think that drives a lot of the differences that you'll see from myeloma versus CD19 malignancies.
Okay, so we have a question from Dr. Annie. From KARMA and CARTITUDE trial, both reported neurotoxicity approximately 18 to 20%. And how many had a reverse in these changes? And is CNS toxicity associated with higher extramedullary disease? So as to put it kind of a broader question, do we have any predictors of, let's say, efficacy and safety of this CAR in myeloma field as of now?
One of the things Dr. Usmani talked about, so first of all, to answer the question, everybody has resolved their neurotoxicity except one person on CARTITUDE died, and it maybe have been related to their neurotoxicity. They didn't go into details, but so that person did not resolve. So that's just the data. That being said, they've looked at a lot of factors that may precipitate the neurotoxicity, and one of them would be disease burden. So the idea would be to make sure you get rid of as much disease as possible, even in the bridging therapy before the cells are infused, so that you can prevent this from happening.
Okay, yeah. So coming to efficacy predictors, so let's start with something antigen expression. So BCMA, so initial CAR, I think IDACEL required 50% BCMA expression. So
right, but then they didn't. I mean, they did initially, but they didn't for the phase 2.
Yeah, so I think that doesn't seem to be really holding on long for this. Any other predictors? So let's see some high-risk myelomas, extramedullary disease, or plasma cell leukemias. Do we have some hints on activity of CAR-T in this difficult-to-treat subset?
I will tell you, we don't know about plasma cell leukemia, and the reason we don't know is those people are excluded from clinical trials, which I think is a big mistake. I think we should try to grab that group of people. It's very hard to treat. So we don't know about that. Extramedullary disease, it does seem like some CAR T patients respond to extramedullary disease. There's some subgroup analyses. It's hard to do without a randomized controlled trial. But yeah, I think there is some possibility of extramedullary disease. And sorry, someone came up with another question. Yeah, sorry.
Yeah, so Dr. Vikram wants to know, what's your opinion on future of CAR-T versus BiTE technology? Means not based on your current data. So probably he wants your opinion without looking
right.
at
I think there are certain people that CAR-T is better and certain people that BiTE is better. So for people that have the ability to come to a center and get it all done and be done with it, they could go by through the rest of their, for a good chunk of time and only have gotten this one infusion of T cells, and then they don't have to think about it. So that's good for people that might want to go back to work or something like that. Now, the flip side is that they have to go and pack up their bags and stay somewhere else for a couple of weeks. And so a lot of people don't have the bandwidth to do that. So in that case, bispecifics would be a good call for these people. I have to say, we've had people on bispecific protocols and they just come in, get their stuff, go, and it's like having outpatient chemo. So, but the problem is it's endless, right? It goes on and on. So those are always plus and minuses. And I think I always say there's enough myeloma to go around. So if there's always enough people filling the Abecma slots, and I'm sure that will be the same when the bispecifics get approved.
Yeah. So on the same line, Dr. Lingraj wants to know, we can target BCMA by CAR-T and also by, let's say, BiTE. So let's forget about the approval issues and regulatory issues regarding the availability, but what would be the ideal sequence in your opinion?
I think I would rather do CAR first because it gives the patient a treatment-free interval, and it's really important for patients to have that because myeloma is a marathon, as I was saying, and they're always on some kind of treatment. So it'd be nice to see if you can get as good a response early on before changing gears.
Yeah. So there is one question from Dr. Rahul Purwar, is the man behind CAR-T, let's say in Mumbai and India. So he wants to know about the universal CAR. What about the safety data on universal CAR?
Yeah, that's the UCAR Selectus program, and he's right. There was a grade 5 event on their study, and they think it's related to the fact that there's such immunosuppression with the Slime F7 CARs, and so people get infections, and so there's all these kind of risk mitigations in place to make sure this doesn't happen as the trial's being reopened now. So we don't know, but there were some PRs on that.
Yeah. So I think one important difference as far as the microenvironment is concerned is a heavily immunosuppressed microenvironment in bone marrow in multiple myeloma, and we see a lot of cells, and that also goes that limited responses we see with the current. So do you think we have some combination approaches that giving a CAR on one hand and making the microenvironment more suitable for this CAR to act? So do you foresee some combination strategies in this area?
I think we're going to have to do combination strategies because 1 year is not enough progression-free survival. 2 years is not enough, right? We want to get to a cure. I totally agree with you that we can manipulate some things about the microenvironment, and that's one of the thoughts we've had about changing cytokines or things like that. I do think the CAR-T itself, it disrupts the bone marrow microenvironment a lot. And so there are cytopenias after a lot of CAR-T experiences, and that has nothing to do with the primary disease that is being used for CAR-T, but rather that there's been this inflammation of the bone marrow. So that microenvironment is already screwed up. But there have been talks about including things like checkpoint inhibitor with CAR T cell therapy, especially as the numbers start to go down in vivo, if you can track that. And then the other thing that has been looked at that we're thinking about doing, and this would be my colleague David Avigan is trying to vaccinate patients with personalized myeloma vaccine as their immune systems are being retrained after the flu side. So it's like CAR, get out all the bad myeloma, let the immune system retrain, vaccinate, and then have some endogenous immunity against myeloma that the patient wasn't able to have before.
Yeah, so I think some exciting development there also. Last question is by Dr. Atul Sharma. So obviously all these very successful therapies has to move in the earlier line of therapy. So what's your thought process on this? What subset probably would benefit by earlier use of CAR? Are they more active if you use them earlier line of therapy?
Yeah, I think CARs should move to second line, I think. And the reason I think that is that it gives patients a treatment-free interval, and that is so important, just that they don't have to come to the oncologist's office and infusion center every 3 weeks. You know, that's a huge deal for them. So I'd like to use that option while they are younger than older, or when they have things going on that they would rather tolerate this now. I think that's how I think about it as a calculation.
Yeah, I think thank you. We will hand it back to the organizers, and thank you, Dr. Neena. It was really nice to listen to you, and thank you, organizers. Back to you.
All right, thanks for having me.
Thank you.
So thank you, Dr. Neena Shah. It was actually a wonderful session. Thank you, Dr. Bhausab, for to keeping the discussion alive, and thank you, chairpersons, for taking our time and keeping the bar on time and finishing on time. So thank you, everyone, and in the interest of time, we'll move on to the next session. So over to you, Rekha.
Thank you, ma'am. Our next chairpersons are Dr. Vinod Raina, sir. He is a chairman, senior consultant medical oncologist, Fortis Memorial Research Institute, Delhi, and Dr. Shailesh Rikhande, sir. He is deputy director, Tata Memorial Hospital, professor and head department of cancer surgery, Mumbai. I request Dr. Vinod Raina, sir, to provide the session introduction. Over to you, sir.
Can you hear me? Yes,
Can you
sir.
hear me? Okay,
Yeah,
good morning to everybody. Hi, Apple, how are you?
good, sir.
It's a great pleasure to be here. I think Jyoti has done a great job of this meeting once again, and thanks for inviting me. Now the topic, I also welcome Dr. Shailesh, who is also the co-chair. And I think the topic for discussion in this session is the advancements in immunotherapy in gastrointestinal cancer. As you know, gastrointestinal cancer forms a big proportion of challenges in medical oncology. And I'm aware of some successful trials or successful reports in esophageal cancer, liver cancer, and to some extent in colon cancer. Now, to throw a perspective into these issues, I think we have Dr. Atul Sharma here. Atul Sharma was my junior colleague at AIMS. He's now the professor and takes care of GI oncology at AIMS. So with that introduction, may I request Dr. Shailesh to introduce Dr. Sharma to go on with this talk, and after that we'll have a panel discussion. And I'll introduce that speaker later on. Dr. Shailesh, is he not there?
Sir, he is joining in a minute or so.
Okay, then
So
we'll go ahead
meanwhile,
with Dr.
meanwhile, I
Atul
request
Sharma.
you to invite Dr.
Yeah.
Atul for the
Yeah,
talk.
Dr. Atul, please go ahead with your talk.
All right. Thank you, sir. Allow me to share my screen, please. Is my screen visible now?
Not yet, sir.
Is it now?
Yes, requesting you to full screen, sir. Good to go, sir.
Okay. So thank you, Dr. Jyoti and Dr. Amit, for giving me this opportunity. So yesterday and day before yesterday, you heard the experts in the field who really put their soul and energy into the immuno-oncology field or immunotherapy. So I must admit that I have very next to the nil experience in personal experience in the immunotherapy in GI oncology, but that this is very, very important topic, and I mainly in the interest of the time will be concentrating mainly on the phase 3 studies, and when the phase 3 studies are not available, maybe the phase 2 studies. The importance of the topic lies in the fact that probably we have close to the 20, whether we see the Globocon data or Indian data, it forms account for about 20% of the cancer burden in the globe or in the India. So I'm not going into the rationale for immunotherapy. The only thing I would like to highlight the basic, most simple cartoon about the action of the immuno-oncology drug. Basically, what happened is these are the T cell receptor. This is the T cell. This is the cancer cell. And whenever the antigen presenting cell is presented to T cell receptor, it activates the T cell function. What had happened at the same time is the PD-L1 engages with the PD-1 on the T cells and blocks this activation, and that's how they escape the immune surveillance. I'll start with the adjuvant treatment because that has been a recent development in this thing, and the study was Checkmate 577, very recently published in New England Journal of Medicine from the Dallas by Dr. Kelly and Crow. So this was a simple study in the sense that the patient who had neoadjuvant chemoradiation and thereafter underwent surgery, and if they have either the T or N positive after the surgery, they were randomized between the two arms, nivolumab for 1 year or placebo for 1 year. The important point to remember is that they did not select their patient based on the PD-L1 expression. And this account, 60% were esophageal cancer and about 40% were the esophageal gastric cancer. They involve both the adeno and the squamous cell carcinoma, and the primary endpoint was disease-free survival. With the median follow-up about 24 months, the median DFS, which was the primary endpoint, was almost double in the group which received the nivolumab. And irrespective of the histology, location of the tumor, and initial and post-treatment disease status, or even the PDL1 overexpression, all subgroup benefit equally. Unfortunately, we do not have the overall survival data, but based on the doubling of the DFS, US FDA have approved, and I think this is the one thing which may be used in the subset of the patient. This was the NEJM publication. So whether the same strategy can be applied to the patient who has received some kind of the perioperative chemotherapy, whether gastric or gastroesophageal junction, or those who received definitive chemoradiation with squamous cell carcinoma or adenocarcinoma low 1/3, we need to wait till we get the results from the pembrolizumab study Keynote 585 and Keynote 975. The bulk of these patients present to us either after the recurrent or metastatic disease, and whether the immuno-oncology drug have any first-line advantage in this subset over chemotherapy was answered in number of studies. To quote, more importantly, CheckMate 648 and Keynote 590. So this CheckMate 648 study was presented this year ESCO also after the initial publication, and the main inclusion criteria were that they should have a squamous cell carcinoma, ECOG should be 0 to 1 without any prior therapy for metastatic or recurrent disease. There were the three groups: Nivo with the chemotherapy, the backbone was 5-FU and cisplatin, Nivo plus EP or chemotherapy alone. Close to 1,000 patients were randomized, and there were the two primary endpoints. One was the overall survival, and second being the PFS in the whole group, and those with the PDL1 more than 1%. When they looked back, it was without any PDL expression. Inclusion criteria did not have to have positivity for PDL1. So Nivo-based combination had improved overall survival than chemo alone in whole group, as well as those who had the PDL1 expression of more than 1%. However, if you see the subset of the patients who did not have PDL1 overexpression, they did not get any benefit. These are the survival curve: Nivo plus chemotherapy 15.5 versus 9.1 months, and all randomized patient 13.2 versus 10.5, both statistically significant with a significant hazard ratio. So I'm not going into the detail about Nivo plus EP versus chemo. So Keynote 590 was another study which tried to address the first-line chemotherapy along with the immunotherapy in esophageal cancer. These were the advanced unresectable metastatic esophageal adenocarcinoma or squamous cell carcinoma without PDL1 overexpression. And 3/4 of these patients had the squamous cell carcinoma histology. And the primary endpoint for overall survival in all patients and those who had a PDL expression of more than 10%. This was the study design, and these are the results. So 12-month overall survival rate were probably superior in those who received chemotherapy and pembrolizumab. 2-year survival also superior, and median survival also was better in the group which received combination chemotherapy. So combination was superior for overall survival in squamous cell carcinoma with the PDL1 overexpression 13.9, as well as those patients who had the whole group of the patient. They did also documented the superior PFS for the patient when the subgroup analysis was done for the patient who did not have CPS for patient who had the CPS less than 10 did not derive any benefit. This is the study from the China, which probably this is their own molecule, PDL1 antibody, pembrolizumab. This was presented in the ESCO 2021. About 600 patients squamous cell carcinoma treatment naive was randomized between this antibody, pembrolizumab with or without chemotherapy. Pembrolizumab with chemotherapy versus chemotherapy plus placebo, and combination treatment improve overall survival, setting that we have some evidence of using immunotherapy with chemotherapy backbone in the advanced unresectable squamous cell carcinoma. Coming to the gastric cancer, so this was the tricks, and this is the latest, probably published last year. I presented a full paper, probably still awaited, at Trixen 4. more than 700 HER2 negative advanced recurrent gastric or esophageal gastric adenocarcinoma were randomized to chemotherapy plus nivolumab or chemo plus placebo until disease progression. We only had the result from the interim analysis. There were two primary co-endpoints, overall survival and PFS. The PFS was superior in combination arm, but there was no difference in the overall survival. The another important thing about this particular study, which may discuss, is that for the PDL1 expression, they chose the tumor proportional score rather than the combined positive score. Whether that had a bearing on the results is not known. Coming to the HER2 new positive, which is also an important probably, and we have evidence for trastuzumab-based chemotherapy that they are superior to chemotherapy alone. This was Keynote 811 study, which was reported and published recently. So they were about close to 700 patients who were randomized, and a pre-planned analysis for 264 subjects were presented. The primary endpoint in this particular study, unlike others, was the overall response rate rather than the survival, and they showed that the overall response was 3/4 in a combination of compared to 50% in the patients who did not receive immunotherapy. The important thing is that duration of response also appears to be better with the combination arm. So we had a few results from the checkmates, some results from the checkmate 649 about a year or two before, and now we have another presentation this year, ESMO, and the full paper is published in Lancet 2021. So this was a study where they tried to use the first-line nivolumab with chemotherapy or ipilimumab versus chemotherapy in advanced gastric or gastroesophageal cancer. Again, close to 2,000, this is a very large study, 2,000 patients randomized in the three group, Nivo plus Xelox. So backbone of the chemotherapy chosen was the 5-FU and oxaliplatin, either Xelox or Folfox. So there were three groups. And if you see the results, then the median overall survival, I'm sorry, there's some, I think, noise from outside. If you really see the median overall survival, it was 14.4 months versus 11.9 months in those who received chemotherapy and nivolumab compared to the chemotherapy alone group. And this again was a successful study which showed that the combination of the chemotherapy and nivolumab may be used. These are the survival point curve for the chemotherapy and nivolumab. 57% 1-year survival, and the survival difference is also documented here. Another subgroup study they did in this particular thing, this was the last study involving close to 2,000 patients. They showed that the patient who have the defective MMR or MSI high, their survival was significantly more than 3 years in the patient who received chemotherapy and nivolumab, and also median overall survival not age in the patient who received combination of the IO. So median survival in the MSI stable patient was just over a year or so. To conclude from this particular study, Checkmate 649, Nivo plus chemotherapy showed improvement in OS, PFS, and other efficacy endpoint. So they are not that all the studies have shown positive result. There are the few studies probably they could not confirm the advantage of the immunotherapy. This was a study reported recently in JAMA Oncology, efficacy and safety of Pembro or Pembro plus chemotherapy versus chemotherapy alone for patients with first-line advanced gastric cancer. This was Keynote 062 study, and the endpoint were OS and PFS. Unfortunately, though it was non-inferior to chemotherapy, but it did not show its superiority over to chemotherapy alone. So they did the subgroup analysis for the patients who had the CPS score of over 10. This was not tested for the statistical significance, but you can see that there is a advantage. Coming to the second line about checkpoint inhibitors in gastric or esophageal tumors, probably there have been a number of studies. In the interest of time, probably I may be taking only 1 or 2 studies, or maybe that I can, when I conclude that time, probably. Only thing is that second line, there is some evidence about the nivolumab for the adenocarcinoma, Attraction 3 study. So this is also a negative study, Keynote 061, large study of gastric cancer or gastroesophageal cancer did not show the improvement for the pembrolizumab. Few lines about the hepatocellular carcinoma, another important point. This was the publication which we saw in last year New England Journal. Use of the atezolizumab plus bevacizumab in unresectable hepatocellular carcinoma versus the sorafenib alone. Updated results were also presented this year ASCO. And this was the 500 patient study. Only thing is that they probably need to have a child score of A. This was the A2 and the BEVA combination. So median survival, which was updated this year, is 19.2 months with the combination versus 13.4 months with the sorafenib. Important other aspect of this study is that the oral responses are also kind of the triple in the combination arm. So these are the survival curves, significant difference. So this is the another study using the nivolumab versus sorafenib in the untreated patient. So nivolumab standard dose of sorafenib. Unfortunately, it did not improve the PFS or OS in the patient who received nivolumab compared to this thing. The only thing is that there were less 3 or 4 treatment-related adverse event in the patient who received nivolumab. The other important point about this immunotherapy in hepatocellular is that this benefit is usually considered to be limited to the patient who had viral disorders. So class comparison also has been reported between the TKI and immunotherapy in the first line setting. Network meta-analysis and combination of ATO and bevacizumab have shown superior survival compared to sorafenib, lenvatinib, and nivolumab. This is the second line study in the pembrolizumab in the hepatocellular carcinoma who failed the sorafenib, and they need to have the childpox class A to be randomized, and this also did not show any improvement in the survival. So this I have included because this was a checkmate initially dose finding study, and then thereafter checkmate 040 randomized control study was presented and published. 148, there were the 3 group of the patients, Nivo plus EP, Nivo plus EP in a different dose, and Nivo alone, Nivo and EP in different dose every 6 weeks. So there were 3 groups. Overall responses were the highest in the patient who received Nivo 1 milligram per kg and EP 3 milligram for Q3 weeks for 4 cycles, followed by Nivo in standard doses 240 milligram over 2 weeks. And also there was improvement in the overall survival, 22 months versus 12.5 months. So I draw your attention, these are the 2 recent publications on the hepatocellular carcinoma, ESCO guidelines and ESMO guidelines. So now coming to the gallbladder cancer, we do not have any phase 3 data. Studies are ongoing. This was the rare cancer consortium from Australia, which included the biliary tract cancer also as part of the rare cancer. And they had an biomarker unselected 39 patients that include 13 gallbladder cancer with the Nivo and EP after first line chemotherapy in most of the patients. There were the 4 responses, and these responses were all in the patient who did not have the MSI high or deficient MMR. And disease control rate was 70%. So duration of the response is up to 23 months. Coming to the CRC, which is another problem basically. So about 5-6% of these patients have deficient MMR. So this was the first study, phase 3 study, where in the microsatellite stable metastatic colorectal cancer, chemotherapy was directly compared to pembrolizumab, more than 300 patients. And if you see the survival, probably the PFS was 16.8 versus 8.2%, and the overall survival was still awaited. But the updated analysis says that probably it is not significant because hazard ratio is crossing 1. The fact to remember here is that number of patients, about 60% of patients who were on the chemotherapy they cross over at that point in time or subsequently to the pembro arm. So this is the second line study in colorectal cancer, Nivo plus EP combination until disease progression. The median overall response was 58% by blinded central review. And at 15 months, 70 of those patients who responded remained without disease progression. And the important another aspect is the median duration of response and median PFS has not reached till now. The last slide about the nivolumab and pembrolizumab in anal cancer, limited data available. It does confirm that they have some kind of the activity. So this is the important slide. Probably I think I have 1 or 2 minutes. So probably this is the just summarize all the studies I have put it. So esophageal or esophageal gastric cancer adjuvant setting by nivolumab checkmate 577 confirmed the overall disease-free survival. Esophageal squamous cell carcinoma, first line advanced setting. You have the combination of Nivo and chemo versus Nivo EP and this thing. Nivo combination is better than the chemotherapy. Checkmate 648. Esophageal adeno or squamous cell carcinoma, first line setting. No benefit of with regard to this OS in the with the pembro, but the DFS benefit is OS or DFS benefit is there. So I take my keynote 590. Another chemo plus carmalizumab in the Chinese study showed this improvement. The attraction 4, personally, I think that they were just PFS benefit and the other endpoint of OS did not meet its survival advantage. So probably keep it with the cross finger. And again, the HER2 new positive tumors, probably we have the study showing that pembrolizumab with the chemotherapy and trastuzumab may be maybe better with regard to the response rate, and you have the another combination. So for the second line setting, we have the squamous cell carcinoma, Keynote 181. Pembro is better than chemotherapy, in particular in the patient who has CPS score more than 10. Attraction 3, Nivo is better than chemotherapy, irrespective of PDL1. So we have a choice. And for the gastric and gastroesophageal junction, we have the Pembro versus Beckley showing no difference. So these are the SCC I probably already discussed. We may take during the discussion point. I would like to stop here. Thank you very much for the patient and kind hearing.
Thank you, Dr. Atul Sharma, for a very comprehensive update about what we are all wanting to do more and more than ever before. What I can't understand, a couple of questions, if I may take the liberty to ask you. Are you able to hear me?
Yes, I can hear you loud and clear.
Sure. So the differences between adeno and squamous, how does one explain that? That's one thought. And how does it happen that there are some studies which show a clear positive response, while there are others which do not show for the same pathology, for the same disease site, for the same disease location?
All right. For the first question regarding adenosquamous, probably if you see the summary slide, probably they are the agents which probably have shown their worthiness in both of these things. So if you really see that they have included esophageal gastric junction adenocarcinoma adjuvant, you see that though about 3/4 of the patient in the adjuvant setting had the adenocarcinoma. With the nivolumab study, they have shown their worth. It has shown its worthiness. In squamous cell carcinoma, also nivolumab-based chemotherapy, when combined with the chemotherapy in the first line setting, it has shown the superior OS. So probably both of them are this thing, showing some advantage. What we don't understand till now is that some agent had shown some particular activity in particular setting, like advanced or first line or second line. But the same agent probably has not, another agent has not shown activity in the same setting. So this is the question which probably is puzzling to most of the investigators, and the exact reason probably is not known.
Right. Are chemotherapy responders, the one who respond very well, also better candidates for immuno-oncology drugs? What do you think?
So in the first line setting, probably they have taken the treatment naive patient. And so it is difficult to say whether the chemotherapy responders only have responded to chemotherapy. We have the evidence in the second line for the immuno-oncology drugs alone used in the second line and showing some responses. So it is difficult to say. The only thing I probably would like to say that at point in time or sometimes in the probably this thing, selection of the patient based on the PDL1 score is making a difference. For the gastric cancer, if they say that CPS score is more than 5, then the immuno-oncology drug will be working. In the first line, and this thing is squamous cell carcinoma or esophageal gastric junction tumor, they say the CPS is more than 10, then the chemotherapy, the immunotherapy will be working. So biomarkers is probably, I think, one of the important aspects for discuss.
Which brings me also to the next question, if I may ask. There are two questions. One is from the box that I see that Prashant Ganeshan has asked regarding first-line therapy in colorectal cancers, microsatellite unstable patients. Is there a subgroup where we have to do combination chemo plus pembro? Can you predict, or is there a way to predict such a subset?
So honestly, probably we don't have that kind of the evidence, but if you personally ask me for the patient who had the deficient MMR or MSI high, and they have the symptomatic disease, then it may not be a bad idea to start with the chemotherapy or combination treatment because you wanted the quicker response. At the end of the day, probably all we know most of the time is that except the hepatocellular carcinoma, where they've shown that responses are quicker with the immunotherapy and bevacizumab. Most of other cancer, whether this is the GI cancer or head and neck cancer, investigators believe that in case you need quicker or faster response, it is better to use chemotherapy.
Dr. Sharma, can you stop sharing your screen? Dr. Prashant Mehta, lead discussant, want to share his screen. Can I invite Dr. Prashant to moderate the question and answer session?
Hello. Yeah, thank you so much, Atul sir. Really a pleasure listening to you and really enjoyed your talk and all the discussion after that. So I'll just share one slide. So can you see this slide?
Yes, sir.
Everybody? Okay. So this is just the hazards which I wanted to show and just the subset analysis which I wanted to draw your attention to. So in the chat box there have been some questions. I'll just address those also. I don't know where the chat box has gone. Yeah. So the first question is whether this data can be extrapolated, and this plot has the answer to that also. Whether this data can be extrapolated to GE junction cancers who are sometimes resected without NSECRT. So first, Atul sir, I would let you present your insights on that.
So the answer to that, Prashant, probably it will be difficult to say yes. Number one, case to case basis, probably you may consider that. To have a definite answer, probably we need to wait till the keynote studies are probably there are 2 studies ongoing which probably have completed accrual and we will getting some distinct pembro. So for the perioperative treatment as well as definitive chemo RT. So until we get that, probably I will request that we hold our horses back.
Yeah. So in this subset analysis, if you look at the GE junction, there are 332 patients. Yeah, 332 patients. There is no difference here. 22.4 versus 20.6, and you can see the hazards of 0.63. The confidence intervals 0.63 to 1.2. So it is not something which is driving the results here. So what is driving the results here is the squamous cell carcinomas mainly, and esophagus, not GE junction, and PDL1 doesn't seem to be important here. Less than 1% also driving this result again. And also I would like to ask you, what is the time point at which you would like to start Nivo after surgery? What time? How many weeks after surgery? Here you can see here less than 10 weeks and more than 10 weeks. People who got it after more than 10 weeks from complete resection. So they have benefited more, it seems.
Better.
Yeah.
So usually, I think most of the people, I think when I spoke to some other people, and they say that close to 3 months is the ideal time when they probably would like
Yeah,
to
close
start.
to, so that is more than 10 weeks.
Yeah.
Anyways.
So because esophageal surgery itself is, I think, not a, I think, easy
Not,
surgery.
yes,
Recovery
yes.
takes time. And if you really compare to the patients, sometimes though we do not have evidence, and we want to start them on some kind of the chemotherapy, usually, otherwise they say that it should be started within 3 months or 12 weeks.
Yeah.
But here, this a situation appears to be little different than that.
Yeah, so this, I really wanted to draw attention to this point, that more than 10 weeks is the time point in this study where, people seem to be benefiting more. So, another question is regarding squamous versus adeno. So I think you already answered that. So I will not take up that question, and that was raised by Dr. Srikhande also. So there is a question from, there is another question regarding HCC. So would you think of IO-TKI combinations as a possibility for something like a borderline resectable HCC and for downstaging? Would you ever consider it? And is there some data to that effect?
So I don't have the data, but I do believe there is study ongoing about that, regarding the neoadjuvant or kind of whatever you want to name it.
Yeah, so there is one phase 2 study, single arm study though, with neo and cabozantinib, and I recently looked it up, and the resection rates were about 80% in that study with the combination of neo cabozantinib. But yes, patients who are transplant eligible, they we would still avoid using IO in those patients
for obvious reasons.
For obvious reasons, yes. So another question is from Dr. Prashant Ganeshan regarding first line therapy in MSI high CRC. Also, is there a subgroup where we have to use chemo-pembro combination, and how do we predict the response? Also, I would add another point. You had raised a point regarding the time to response. So time to response probably is very quick with IO. What I remember is with MSI high tumors, it's about 8 weeks, 6 to 8 weeks. So what is your thoughts on combination of chemotherapy and IO in this subset?
So I think probably the Nevo study, they have tried that, the IO combination.
Yes, sir. And
IO
and chemotherapy, I'm talking of chemotherapy and IO combination.
So that probably is going to be, so that is going to be the next questions to be answered.
Yes.
But right now, outside the clinical trial, but I personally believe, like you said that, Prashant, you said that probably with the IO, we expect response in about close to 8 weeks or so. But
Yes,
if you use in a fit patient, either 3-drug combination, FOLFIRINOX or
they also do respond. Yes.
FOLFIRINOX. So
Yes.
they respond probably sooner than that.
Okay, sir.
But
So
if a stable patient with the MSI high, there is no question that we should be starting on the IO if affordable, available, and this.
Okay, sir. So there is another question from Dr. Rahul Purwar, and he's a primary Indian researcher in the field of CAR T cells, and I had the pleasure of listening to him a few times. So he asked, in your opinion, how the society, and this is to Dr. Jyoti also, should collaborate with pharma and government to bring the immunotherapy trials in latest IO therapy to patients in India?
I think just to probably before Jyoti answers, this morning only we were discussing during our executive committee meeting about this particular aspect.
Yeah.
And whether you want to do IO-based trial in the country, or you want to have the, I think, kind of the study where you want to use little less dose of whatever people have been using, duration of the 2 doses is increased, then probably all these things that this thing government has to chip in. So no pharma industry will be able to or will be supporting this kind of study. And I think as a society, we need to move forward with this.
So there's one last question from Dr. Surojit. So in microsatellite stable cancer, which are more resistant towards pembro or Nevo-EP combination, how these therapies can be taken forward? Can these still be effective? Can we sensitize them towards IO in some way?
So I think there have been a study using some kind of the radiation in the past, because radiation also is considered. They have been studied using some other kind of study, but I'm forgetting the name of the agent, which probably tried to sensitize these cells with the immunotherapy. That has been studied, presented, published, but it did not show that this improved the outcome. It was again by the Lens group, I believe, and they have shown that it is not useful.
Yeah. So with that, I would end my discussion. If there is no other question, thank you so much, sir. Really a pleasure and privilege interacting with you here.
Thank you. Thank you very much.
So thank you very much, Dr. Sharma, for this excellent talk. Dr. Sharma is a co-organizing secretary also with me, and it was great working with him always, including in this meeting. Thank you very much for the esteemed chairpersons, Professor Raina, who was my mentor and teacher, and it is really great to have you serve with us. Dr. Shikhande, who is my colleague and friend here in TMH, and it is always great to interact with you in all the forums.
So
Thank you, Prashant.
Dr. Rena is mentor to most of us, those
Yeah,
who
for
graduated
our
from
generation
it.
of oncologists. So it's really great pleasure to have him here. And also Prashant for this excellent discussion,
Thank you
as
so much.
always. So
Thank you.
thank you. It was a great session. And Rekha, over to you.
Thank you, ma'am. Our next chairpersons are Dr. Ahmad Ijaz Masood, who is Professor and Head, Department of Clinical Oncology, and Dr. Bharat Rekhi, sir, who is Professor, Department of Pathology from Tata Memorial Center, Mumbai. Over to you, sir. I request Dr. Masood to provide the session introduction.
Dr. Masood, you are muted.
You are muted, sir.
Please unmute yourself.
Okay. Is it clear now?
Yeah.
Can you hear me?
Yes, sir.
Okay. Thank you very much. First of all, I would like to thank Dr. Atul Sharma, Dr. Jyoti, and Dr. Amit for making me proud to be part of this event. And it's a wonderful event. And on behalf of all SAARC countries, as a president, I'm thankful to all of you for this. This session would update all of us, and not only the people from the doctors and other people in the South Asia, that we would love to have updated knowledge of all these immuno-oncology centers. So I would like to once again thank you, all of you. I'm sorry that I was a bit late for this event, and now I would like to continue with this. Please update and start the session now.
I request Dr. Bharat Rekhi, sir, to invite the next speaker.
Thank you, Rekha and Dr. Jyoti. Good morning, everybody. At the outset, I must thank Dr. Jyoti and the team for inviting me to chair this session. Although my areas of interest are sarcomas and gynec, but in the spirit of this great meeting, I'm happy to introduce this speaker, Dr. Zaigan Abbas Rizvi, who will be delivering a talk on robust tumor immunity by high dietary salt is dependent on NK cells and gut microbiota. Dr. Rizvi is a junior research scientist at Dr. Amit Awasthi's lab in Immunobiology Laboratory, Infection and Immunology Center, Translation Health Research and Technology, Institute, Faridabad. Dr. Rizvi, the virtual stage is all yours.
Yeah, thank you, sir, and a very warm good morning to all of you. I request the organizers to kindly help me with the sharing of the screen. Okay, it is there. So I hope my screen is visible to all of you.
Yes, sir.
Yes, sir.
Yeah, so once again, a very warm good morning to all of you. I would like to take this opportunity to thank Immuno Oncology Society of India to invite me to present my work. Today's talk is titled Robust Tumor Immunity by High Dietary Salt is Dependent on NK Cells and Gut Microbiota. So as we all know, sodium and its ion take up around 90% of the total osmotically active solute, and they contribute to a lot of health, human health and physiology, especially in maintaining the balances of the ions, in prevention of loss of water, as well as regulation of the body fluid. What is known about the high salt is that usually normal dietary intake of salt is limited to 1.5 gram per day, but if you go slightly above that level, it is considered as a high diet, and a high diet is associated with lot of pathophysiological changes in the body, and it especially influences the liver, intestine, gut, and urine, as well as it causes lot of changes in the hormonal and metabolic changes. Especially it influences the microbiota of the gut, which are lactobacillus, oxalobacter, as well as rothia. Now, yeah. So recently there are a couple of studies which have pointed out that high salt diet is able to promote inflammatory response, and they have shown that intake of high diet salt, especially those in the Western world, is able to increase the pathogenic TS17 response, and they are able to prime the macrophages towards M1 type phenotype, which is more of pro-inflammatory macrophages. And then there are also reports that apart from TH17 and macrophages, it also influences balances of TH1, TH2, and as well as balance between regulatory and effector T cells. So we asked this question: can we exploit this inflammatory properties of salt to overcome the tumor regression in the tumor microenvironment? So what we did is we used this B16 melanoma mice model, and we took 3 different batches of animals. One batch of animal was kept on normal diet, the other was kept on low salt diet, which is which is normal diet in addition to 1% NaCl, and the third group contained high salt diet, which was normal diet in addition to 4% NaCl. And we found that high salt diet was able to suppress B16 melanoma as well as LLC tumor and lung metastasis, and we got almost 2-fold reduction in the tumor burden in case of B16 melanoma as well as LLC tumor, and there was almost 3- to 4-fold decrease in the metastasis of B16 to the lungs. We further use this HSD to find out whether supplementation of HSD post surgical removal of the tumor is able to suppress the growth of the melanoma. And what we did is we after the incorporation of the B16, we let the tumor grow. After 15 days, we surgically removed the tumor, and we started the high salt diet. And surprisingly, the high salt diet was able to suppress the tumor even post surgical removal of the tumor. Next, we in order to monitor the progression of the lung metastasis, we use this 4T1, which was luciferase construct, and we did an in vivo imaging, and we can clearly see that the lot of lung metastasis 4T1 cells are absolutely gone from HSD fed mice. Now, by the time we were carrying out our experiment, there were a lot of other publications indicating that high salt diet can mediate tumor immunity. And they mainly focused on, for example, myeloid-derived suppressor cells, or the osmolarity regulation of high salt diet to induce tumor immunity. So next, in order to find out whether the tumor immunity because of high salt diet is coming through osmolarity or not, we use isoosmolar mannitol, which is 80 nanomolar mannitol, and injected them and put the mice on this 80 millimolar mannitol through oral dosing. And it was found that mannitol, which is isoosmolar to high salt diet, was not able to rescue the mice in terms of tumor burden. At the same time, the mice fed on high salt diet, since high salt diet is already implicated in lot of cardiovascular diseases, as well as a lot of changes in the liver and kidney function. So we, in order to find out whether high salt diet given to mice bearing tumor has any adverse effect on the cardiovascular function or kidney and liver function. And to our surprise, there was so we did a ECG for the heart function, and LFT and KFT for liver and kidney function, and we found that there was no any significant difference between high salt diet fed mice as well as the tumor as well as the normal healthy mice. Since the previous studies have suggested that this tumor immunity mediated by high salt diet is mediated by suppressive immune cells, and so in order to profile the immune population and to find out which immune population is particularly influencing this tumor immunity, we did a complete deep immunophenotyping of the tumor infiltrating lymphocytes, which is still from the tumor mice and tumor mice fed with high salt diet. And our results plotted in the form of T-SNP plot shows that there is a very marked increase in the NK cell population as compared to the other cell populations, CD4, CD8, and gamma delta T cells. Since the major population that was perturbed in presence of high salt diet was NK cells, we further wanted to validate whether the effect of high salt diet is coming mainly through NK cells, or there are other T cells also involved in the tumor immunity. So what we did, we took this RAG1 knockout mice, which essentially do not contain recombinase enzymes which are important for T cells and B cells maturation, and we found that in RAG knockout mice, the tumor separation in presence of HSD was equally good as in case of wild type mice, and there was almost 3 to 4-fold reduction in the tumor burden. Next, in order to validate whether the effect is mainly coming from NK cells and not from other myeloid lineage immune cells, we use this anti-NK1.1 antibody to deplete NK cells in RAG knockout mice. So now we have a mice which is already depleted in T cells, and we are now depleting NK cells also. So to our surprise, the NK 1.1 antibody mediated depletion of NK cells in the RAG knockout mice resulted in loss of protection, and there was the tumor growth was almost equivalent to mice which were kept on normal diet. Next, we found that in the presence of high salt diet, there is a substantial increase in NK cells almost 1.5 to 2%, twofold increase in the NK cell population, as well as we also checked the other functionality marker of NK cells, which are 107 and CD96. So 107 is basically the degranulation marker, by which NK cells mediate direct tumor killing, and CD96 is basically the inhibitory marker. So we found that even though there is no significant decrease in CD96, but the CD107A levels were significantly increased in presence of HSD. Also, we looked at the PD-1 expression on NK cells and other immune cells population, and we found that PD-1 expression on NK cells and other immune populations, which is not shown here, is also significantly decreased in presence in mice fed with HSD. Next, we also wanted to study the metabolomics profile of the HSD fed mice, and we did a LC-MS/MS based serum metabolomic profile, and we found that particularly elevated levels of serum hippurate in the HSD fed mice, but not in tumor or healthy control mice. Now, hippurate is one metabolite which is known to be present in the responder population of anti-PD-1 immunotherapy, and hippurate and patients, clinical patients who in which the hippurate levels are elevated are known to have a very good response against anti-PD-1 therapy. So we use this. Since hippurate was one of the metabolites which was upregulated in presence of HSD, and HSD was also somehow lowering the expression of PD-1, we thought that whether combining salt with anti-PD-1 therapy could produce some combinatorial effect, thereby reducing the tumor progression. So what we did is we used the combination of low salt diet in combination with suboptimal dose of anti-PD-1, and when we deliver it to the mice bearing tumor B16 tumor, we found that even the suboptimal dose of anti-PD-1 was significantly able to reduce the tumor burden as well as improve the survival of the animals. Yeah. So next, since now hippurate is one of the co-metabolites which is known to be secreted by the body as well as the gut microbiota. So since there is a connection between hippurate levels and the gut microbiota abundance, we asked whether HSD mediated tumor immunity involves gut microbiota. So to answer that, we created aimed mice, which are antibiotic induced microbiota depleted mice. For this, what we did is we kept these mice on an antibiotic cocktail containing ampicillin, vancomycin, metronidazole, and neomycin, and also added amphotericin B to take care of all the fungal contamination. And when these mice were kept on this antibiotic cocktail for 3 weeks, the gut microbiota of these mice were significantly depleted as validated by the CFU count, and we use these mice to implant B16 tumor and study the progression of tumor in presence or absence of HSD. Now, to our surprise, we found that when the gut microbiota of these mice were removed or depleted, the tumor progression was completely abrogated, and even the survival of the B16 bearing mice in aimed mice was completely abrogated. And correlating to it, the NK cells levels in these aimed mice were also abrogated.
Dr. Rizvi, requesting you to conclude, sir, because we are behind the schedule. So you can
just 2 to 4 minutes. I'll wind up.
So as early as possible. Sure.
Yeah. So next, in order to find out what particular species of bacteria are modulated in presence of high salt diet, we did a complete NGS of the stool samples obtained from high salt diet, normal diet, and tumor-bearing mice, and we found that one species of bacteria, which was Bifidobacterium, which was particularly elevated in presence of HSD diet, so since HSD was elevating the Bifidobacterium level, we next asked whether transferring the fecal matter from the HSD fed donor mice to the aimed mice could impart tumor immunity. When we did this tumor FMT transfer from HSD fed donor mice to aimed mice, we found that the mice receiving FMT from the HSD fed donor mice, which is called as the responder mice, they showed regression in the tumor burden as well as improved survival. And yeah, and there was also an increase in the Bifidobacterium abundance in the gut following this FMT. As well as we could see there is significant increase in the NK cell population in these responder mice receiving FMT from the donor mice. The hippurate level also corresponded to the HSD fed mice. In the last experiment, what we did is
Dr. Rizvi, requesting you to conclude, sir. We are behind the schedule.
Sure. So in the last experiment, we use this. So since Bifidobacterium, there are already reports that Bifidobacterium in the tumor condition can leak out from the gut and reach to the tumor microenvironment and localize there. We did a gut permeability assay, and we found that HSD, in presence of HSD, the gut permeability of the mice, tumor-bearing mice, was highly elevated. This elevation also lead to the leaking of Bifidobacterium, which then were localized in the B16 melanoma, and we found that the B16 melanoma Bifido concentration was almost 7 to 10% increase as compared to the tumor alone condition. Next, we use intratumoral injection of Bifidobacterium in combination with anti-NK 1.1 to find out whether there is any interplay between Bifidobacterium and NK cells in the tumor environment, and we found that in presence of Bifidobacterium intratumoral injections, the tumor burden was significantly reduced. But once we supplement this Bifidobacterium with anti-NK 1.1 injections, the effect was abrogated. And we could see that similarly, NK population was significantly modulated in presence of Bifidobacterium. So we conclude by saying that in normal diet, there is increase in tumor burden. It leads to hyponatremia condition, and because of this hyponatremia condition, NK cells somehow shows less activity. But once we feed these mice with high salt diet, there is increase in sodium concentration, which may directly or indirectly lead to increased NK cell number and activity. It also leads to leaky gut permeability, through which the Bifidobacterium may escape and localize in the tumor, and leads to improved NK cell activity and improved tumor regression. So we published this in the Science Advances, which was covered by, I would like to especially thank my mentor, Dr. Amit Awasthi, for providing me this brilliant opportunity to work on this project. I would like to thank all the funding agency and support from Animal House, Flow Cytometry Unit and Microscopy Facility at THSI. Thank you very much. I would be happy to take questions.
I request Dr. Bharat Rekhi sir to invite the next speaker.
Thank you, Dr. Rizvi, for this wonderful talk. And now I would like to invite the next speaker, Dr. Amit Awasthi. Dr. George Ibrahim, who is the Assistant Professor at the Department of Medical Oncology, Regional Cancer Center, Trivandrum, who will be sharing with us the data of the Immuno-Oncology Society of India. Dr. George Ibrahim, the stage is yours.
Thank you, sir, for the introduction. Is my screen visible?
Yes, please full screen it.
Yeah, sure. Thank you for this opportunity to present the IOSI data. I will be covering the brief background, the Indian data with regard to the efficacy, toxicity, the reasons of stoppage of immunotherapy drugs in India, the biomarker evidence from India, and so immunotherapy has emerged as a new treatment option for cancer care in the last 1 decade. The real world data for immunotherapy agents from low and middle income countries is scarce. It is mainly due to underrepresentation in multinational clinical trials and also lack of accessibility to this expensive mode of treatment to the common population. So in this study, we aim at the assessing the safety and the efficacy of immune checkpoint inhibitors in a multicentric Indian setting. So there were 13 centers which were participated in this study. It is a retrospective analysis which was carried out among patients who received immune checkpoint inhibitors for various indications. The objectives were to enumerate the overall survival and the progression-free survival of immune checkpoint inhibitors, and also to study the prevalence of toxicities and the tolerance. So it was a retrospective multicentric observational study. The data was collected from August 2014 to October 2020 from 13 centers in India. We looked at the pattern of care, PFS, OS, and toxicities, and the data was analyzed. Moving to the results, we have 1,011 patients from 13 centers which was collected over a period of 5 years. The median age of the population was 59 years and males were 3/4 of the population. The median number of cycles of immune checkpoint inhibitors which was used were 5, and the median duration of therapy was 3 months, which had a wider range, ranging from half a month to more than 30 months duration. So we looked into specifically why immune checkpoint inhibitors were stopped in this population from various hospitals. So the most common reason why immune checkpoint inhibitor was stopped was disease progression, which accounted for 68% of the patients where immune checkpoint inhibitors were stopped. The subsequent most common reason which we found was the logistic constraints, especially with regard to financial constraints. This highlights the important aspect that 1/4 of the patients had to stop the drug because of lack of continuation facilities due to financial reasons, and most of them ended up being lost to follow-up, that because they couldn't afford the further continuation of the drug, they did not report back to the hospital. So this constituted around 25% of the population, and this mirrors the real world data of immune checkpoint inhibitors in Indian setting. Toxicities, the reason of stoppage due to toxicities constituted 2.4% in 22 patients, and there were some miscellaneous causes like myocardial infarction, stroke, COVID, and other related infections which accounted for the stoppage in the other patients, which constituted around 3.8%. Among the patients, hypertension was the most common comorbid conditions, followed by diabetes. But there were patients with ischemic heart disease, hypothyroidism, and chronic kidney disease in the range of 2 to 3%, which also received immune checkpoint inhibitors. With regard to the indications for use, most common indication which we found, that is 65% of the patients received immunotherapy for non-small cell lung cancer and also head and neck squamous cell carcinoma. Renal cell carcinoma constituted 9.6% and melanoma constituted nearly 9%. The other indications like gastrointestinal, hepatocellular carcinoma, genitourinary, sarcoma, small cell carcinoma, and gynecological indications and breast were relatively rare. But most common indication in our study was lung cancer and head and neck squamous cell carcinoma. With regard to the response to the therapy, we found that the overall response rate, which is the sum of complete response and partial response, was nearly 25%. And this actually is comparable with the data from the West, and also these with regard to the clinical benefit rate, which included complete response plus partial response plus stable disease, constituted 45% of the patients. Primary progressive disease, that is like progression, happened in 37% of the population. If we go into the efficacy results, we had a median follow-up of more than a year, which was 14.1 months, and there was 616 events of progression with a median progression-free survival of 6.4 months. Remember that this is the overall data, so it had multiple cancers included, and this is probably an umbrella data analysis covering all the cancers where immune checkpoint inhibitors were received. The 1 year and 2 year PFS was 35 and 24% respectively. With regard to the overall survival crossed 1 year. It was 13.6 months, the median OS, and also the 1 year PFS was 52 and 2 year PFS was 34.7%. With regard to the outcomes for individual cancers, NSCLC, the PFS was 7.1 and OS was more than a year. For RCC, it was 7 months and median OS was 8.3. As expected, head and neck squamous cell carcinoma, most of the patients which we had were selected in second line head and neck squamous cell carcinoma where nivolumab was used, and the data is actually as expected. The PFS and OS is less for head and neck squamous cell carcinoma, 4.2 PFS and 9.3 OS. With regard to cutaneous melanoma, the PFS was 6.1 and 11.8. And we had data for urothelial carcinoma, gastrointestinal carcinoma, HCC, small cell carcinoma, and sarcomas. However, these numbers are less among the entire data set. We also looked into the PDL1 analysis, and we had a subset analysis for 92 patients with NSCLC. However, the numbers were small to give a definite interpretation, and this was the data with regard to the PFS, which showed that just had a preliminary data which shows that more than 50% PDL1 had a higher progression-free survival when compared to patients with PDL1 less than 50%. However, to interpret this in a larger setting, it needs a larger sample size and more PDL1 testing needs to be done in our population. We had 1011 patients and PDL1 testing was available only for more than 11% of the population, which was 112 patients. So with regard to the overall survival, there was no much difference between the different categories of PDL1 in NSCLC patients. Coming to the safety data, the commonest toxicities which we found was anemia, neutropenia, fatigue. The most common clinical toxicity was fatigue with immunotherapy, which was 8 to 10%. There were patients who described myalgia and skin rash also. With regard to the autoimmune toxicities, we have pneumonitis, which was common in 3.8% of the patients. There was one case of grade 5 pneumonitis, one case of toxicity related death was there in our study. There were no other toxicity related death other than pneumonitis. The other common toxicities which were seen were nephritis, colitis, thyroiditis, hypophysitis, hepatitis, and there were also cases of dermatitis. So severe toxicities accounted for nearly 1 to 2%, which was actually colitis, hepatitis, pneumonitis, and nephritis. There was one toxicity related mortality, which was due to grade 5 pneumonitis. So the discussion, the median OS and PFS in real world setting is comparable to the Western data. We have patients with poor ECOG performance status, which was included. There were patients with ECOG performance status 3 also included in our study, who received immune checkpoint inhibitors for various indications. With regard to the PD-L1 status as a biomarker, we have immature data because the events were not crossing the median 50%, and the numbers were also less. However, we need a larger set of data to with more PD-L1 testing being done to know the actual PFS and OS benefit with regard to the PD-L1 subcategories. It is safe and well tolerated with rare incidence of severe toxicities. So accessibility and cost remains a barrier to immune checkpoint inhibitors in low and middle income countries, with our data showing that a quarter of the patients had to stop the drugs due to financial reasons or logistic issues. Missing data is there, which is a limitation of our study because the data was retrospectively collected from multiple centers, and the data was analyzed from the data which was available to us. Biomarker testing was done only in a few patients, so it is not enough to give definite conclusions. So to conclude, real-world multicentric Indian data, predominantly with short-course immune checkpoint therapy, is found comparable with respect to the efficacy and the toxicity to the published international literature when compared with the standard immune checkpoint therapy, and this merits wide recognition and exploration in large randomized cohort for reproducibility and potentially practice-changing implications. I would like to thank all the co-authors who are involved from multiple centers for contributing their patients, and also for their patient listening to all our emails and also updating our data for helping us to generate such a large data of more than 1,000 patients. And these are the centers which were involved from all over India. And thank you, IOC, for this opportunity to present for this session. Thank you.
Thank you, Dr. George and Dr. Rizvi, for this wonderful talks. Now I request Dr. Prasant Ganesan sir to moderate the question and answer session. He is Additional Professor, Department of Medical Oncology at Jawaharlal Institute of Postgraduate Medical Education and Research, Pondicherry. Over to you, sir.
Thank you very much. The entire team from IOSI needs big congratulations for the excellent talk that they have put up and the study that was presented by George. So we had very interesting two papers from the Indian setting, one from the basic science and one from the real world data, two ends of the spectrum, but both very relevant to us. So coming to the talk by Dr. Rizvi, so he presented a very interesting and provocative data on the use of high salt diet to improve anti-tumor immunity. The three major findings of his study. One is that a high salt diet, when given to mice, increases anti-tumor immunity, and which could probably be kind of okay to use a lower dose of anti-PD-1 kind of drugs. And of course, this entire thing seems to be modulated by gut microbiota. So one question for Dr. Rizvi is, Dr. Rizvi, how do you see this translating into the clinic? Because I think this data is there regarding autoimmunity and high salt diet, but not much has translated in that setting as of now. So in the setting of cancer, how do you see this translating at this point of time? How do you conduct clinical trials in this space?
Yeah, thank you. So one thing to keep in mind regarding the experimental settings of HSD in tumor is that we are dealing with tumor-bearing mice. We are not dealing with healthy mice. So all those autoimmune diseases have been reported in healthy mice. and as well as healthy human settings. Now, since tumor, in most of the tumor conditions, it has been reported that hyponatremia is one of the factors. And in our settings, when we fed the mice with high salt diet, the hyponatremia condition seems to be resolved. And we also found that there is an increase in excretion of the excess of salt. So it may be possible that the high salt diet is actually replenishing the sodium and chloride ion concentration that has been lost due to hyponatremia. And in this way, they are able to modulate the function of the immune cells.
Thank you. One more question was high salt diet can cause several health effects like inflammation, calcium loss, hypertension. I think you alluded to that. Could increased water intake and added hydration help? Is there any data in this support? Is one of the questions which were there in the chat box. Can you take that?
I'm not sure whether anybody has looked into the water intake and hydration data, but as far as our data, because we also monitored the feed and water uptake of these high salt fed mice, it is true that high salt diet mice, they take up a lot of water because of this increase in salt. But I'm not sure any other published literature is there on the water intake and added hydration.
I think this we should very interesting study. Congratulations, Dr. Amit and Dr. Bas for this effort. We will watch this space. I think what's also interesting is note that many of the earlier studies in the cardiovascular settings have noted that Indians generally have a higher salt intake than the rest of the world. So this is in that context, this is also something which we should watch and see how this can really affect us. Are we really more responsive to immune therapies that we don't know? We have data from the Immuno-Oncology Society paper presented by George, which says that our responses are very similar to what is seen in the West. So very excellent paper from George. Some questions for George in the chat box. So Dr. Atul wants to know whether do we have initial response rates data in those who progressed and those who discontinued because of financial toxicity. Among those who stopped because of costs, what was the median number or range of cycles? Dr. George, you want to take it?
That was a good question. Actually, when we looked into the overall data, the response rate was 25%. We haven't looked into the subset of which patients which have progressed, but most of the progression actually happened between 4 to 8 cycles. They had an initial response. There were a set of patients who had progression happen within 2 or 3 cycles, and they were excluded. So the commonest time where progression happened was within the first 3 or 4 cycles. The second common place where progression happened in our study was they went back after the 4th cycle response assessment, and when they came back for the 8th cycle, post 8th cycle. So between 4 to 8 cycle was the second common place where progression happened. So if you look into the patients who had progression, specifically, the most common place where progression happened was 1 to 2 months of treatment, and the second common place where progression happened is from 4 to 8 cycles. With regard to the financial toxicity, there were 2 categories of patients in this. First is the patients who had reimbursement from railways or any other government setting, who kept on continuing the drug without any problems. But there were a set of patients who who were buying these medicines by their own pocket, from their own pocket. In those people, most of the stoppage happened by around 6 to 7 cycles as a median. But there is a wide range. Most of them were able to afford maybe 4 to 5 cycles, and then they had to stop because they realized that they were not able to continue it further, and they opted either they came back and opted for a different therapy like a chemotherapy, or they opted for continuing in another center, or they did not come back at all. So that was what happened. to the patients who are self-paying. For self-paying patients, I think beyond 8 to 10 cycles were very difficult for them. I think it varies with different centers. In a private center, it would have been much more longer. But this, if it had been a government setting or in places like TMH, the most of the stoppage happened between 4 to 8 cycles, maybe 6 or 7th cycle.
Thanks, Dr. George. The next, all the burning questions is with regard to the same thing. Has reduced doses or longer intervals between scheduled doses been tried owing to financial constraints in these patients? Other question. Is there any data on that? Somebody after 4 cycles, they could not afford, so you cut down the dose, or instead of 2 weeks, you give it 4 weeks. I think in practice, people do all those things. So
we have been practicing low dose immunotherapy also, which is like if patients who are not affording, they have been tried with 40 mg nivolumab doses, but the numbers are less to, we haven't done a separate analysis on the low dose pattern as such, but reduced doses has been tried in few patients. But with regard to the duration of treatment, most of the median duration of treatment, as I mentioned in the study, was 3 to 4 months. So most patients actually ended up getting treatment for around 3 to 4 months, and either they progressed or they continued the treatment, but the median duration of treatment was 3 to 4 months.
Thank you, Dr. George. Those very, very interesting discussions, very interesting studies. Congratulations to both authors once more and to the entire team. I think in the interest of time, we are forced to wind up the discussions. Thanks once more to Jyoti and the entire organizing team for giving me this opportunity.
Thank you very much, both the speakers. Indeed, it was excellent to hear you out. And I would like to make one comment about this Immuno-Oncology Society data, which is a real world scenario. And I would like to, put on the records for all those 13 centers who really were very vital, because this kind of data to generate from our own population, from our own practice is very, very meaningful, because this is the real world setting. And how we all know, because of several challenges, our practice varies. So what is in real world the efficacy and safety, that is important to document, with the caveat of being retrospective and heterogeneous from different centers. It's still giving us an assurance that what we are doing is still meaningful for the patients. And definitely, because this data is being collected over the last few years, we are getting wiser day by day. And also there are certain kind of assistance, certain kind of schemes which are coming up. Hopefully in future we will be able to present more robust prospective data within the umbrella of IOSI. So that would be my comment. The second, my co-organizer, Dr. Amit Avasthi, and his team, they have done an excellent research on basic science, and I would like a quick comment from Amit on this. You're mute, Amit.
So I think the questions what it asks about how we can take this to the clinical setting. I think the couple of things from this paper is actually coming out. One is definitely we can reduce the doses of anti-PD-1 and PD-L1 therapy, which is very costly and it's financially very toxic. So if we can combine the low dose of salt and low dose of PD-L1 therapy in some of the patient, and this is as we are discussing with Dr. Jyoti, and perhaps we are going to start somewhere a clinical trial soon for this. And the second thing is, I know the salt is doing a lot of other things, cardiovascular dysfunction and a lot of other problems. So one we can have the low dose of salt combination of anti-PD-L1 therapy low dose, right? The second one is definitely we can also try to think doing this bifidobacterium together with anti-PD-L1 therapy, because if we replace salt with the bifidobacterium, we are seeing the same effect. So I think these couple of combination, we are still in talking with Dr. Jyoti and other clinical partners, and hopefully we will be starting this very, very soon. Thank you.
Yeah, so very well said, and I hope that this kind of hypothesis should come into clinics, so bench to bedside, and should help many patients. In the interest of time, we need to move. So thank you very much, Prashant, for this excellent discussion. Prashant is a very dear colleague and friend from my All India Institute Residency times. It is always a pleasure to have you, Prashant. Also, I'm very thankful to our chairpersons, Dr. Masood, who's SFO president, and I'd like to put on records his efforts to put all the collaborative efforts from SAARC countries on board, and we collaborate on many fronts. So thank you, and also thank you to Dr. Bharat Rekhi, who is an eminent researcher from my own institute, dear friend and colleague. And it is always, a pleasure, Dr. Bharat, to have you in such original data session. Thank you very much.
Thank you, ma'am. Now I would like to invite our chairpersons, Dr. Santosh Chauhan, sir, who is Senior Scientist, DBT Welcome and EMBO GIN Fellow, Institute of Life Sciences, Bhubaneswar, and Dr. Prakash Chitalkar, sir, who is Director, Shri Aurobindo Cancer Institute, Professor of Medical College, and General Secretary of Taiken Foundation. I request Dr. Santosh Chauhan, sir, to provide the session introduction. Over to you, sir.
I'm audible, Rekha?
Yes, sir.
Thank you, Rekha. Thanks, Dr. Vajpayee, Jyoti, and Atul and Amit for providing me this opportunity. And it's very interesting sessions, both basics and translation. I'm enjoying it. So I will start with this saying that in recent past, interest has really grown tremendously in cell-based cancer therapies. This session will cover the knowledge and newer discoveries in CAR T cell therapy and other cell therapies and their status in India. So the cell-based therapies involves modifying a patient's own cells or cell from a donor to fight disease or alleviate medical conditions, including cancer. As we all know that T cells are one of the most potent immune cells in the body that can fight with foreign pathogens and the foreign bodies and the cancer cells. In that aspect, the CAR T cell therapy or chimeric antigen receptor T cell therapy involves introduction of genetically engineered CAR T cells into the cancer patients as to recognize and clear the abnormal, so-called abnormal, they are abnormal cells in cancer cells. So in this area, in 2017, 2 CAR T cell therapies were approved by FDA for leukemia in childs and elders. In India, very recently, I think in June 2021, Tata Memorial Hospital and IIT Mumbai team performed the first CAR T cell therapy at ACTREC. So I feel that these therapies are not fully developed yet, and they are in infancy stage. There are large number of opportunities and scopes in improving the cell-based therapies against cancer, including the CAR T cells therapy. For example, effectiveness of CAR T cells therapies in solid cancer is not demonstrated very well. So there is a scope there. Beside that, there is a low success rate for several reasons, unknown reasons, and the most important thing is very high cost are the major roadblock for CAR T cell therapy. I'm sure in coming years, India will play a critical and significant role in this area. With this note, I welcome you all in this session on cell-based therapies, including the CAR T cells therapy. Thank you. Over to you, Rahul.
I request Dr. Prakash, sir, to invite the speaker.
Good morning, and thank you very much, Indian Society of Immuno-Oncology and Dr. Jyoti for giving me this opportunity. It's a great privilege to invite Dr. Rahul Purwar. He's the Associate Professor in the Department of Biosciences and Bioengineering at the Indian Institute of Technology, Mumbai. And he's the lead worker in this great Indian effort to actually start CAR T cell therapy for our huge number of our needy patients. And he, along with Dr. Gaurav from Tata Memorial, have actually taken the first steps now in the last couple of months after a long odyssey of efforts which we've been privy to for the last couple of years. So without wasting too much time, I will request Dr. Rahul Purwar to make his presentation on CAR T cell current status and future in India. Dr. Rahul Purwar, please.
Thank you. In India regarding development of CAR T cells and how we traveled this journey from lab to clinic. Okay. Just a conflict of interest. And so here we will, so what we have been doing is translation research, where idea was that what we develop in the bench, it goes to bedside, and ultimately whatever results we see at the bedside, we learn from something from them and again go back to the bench and try to fix it. So bench to bedside and then bedside back to bench side. This was the idea to start this project to bring effective CAR T cells in our country and to our patient. We have heard a lot about this excellent discovery by Jim Ellison, who gave us oration last year in IOC meeting. And this year, 2 days back, Tasaku Honjo, another Nobel laureate who discovered PD-1, PD-L1 pathway, gave an excellent presentation. And we heard a lot about how these checkpoint inhibitors are changing the life of the patients throughout the world in multiple cancer types. Excellent discovery and a lot of hope for the patients who were basically did not have that much hope from other available treatment, really making a difference in thousands and thousands of people's life. Right? Another revolution which was happening in addition to the checkpoint inhibitors are the CAR T cells or the cell therapy based treatment. And this revolution is mainly led by two brilliant scientists, Carl June, who was working at University of Pennsylvania, doing a lot of work on CAR T cells, in fact, treated first patient on CAR T cell with using his CD19 CAR T cells. And another gentleman at NCI, Steve Rosenberg, did a lot of work and in fact continuing to do a lot of work on the tumor infiltrating lymphocytes and IL-2, which some of you may be using as well. So there's a lot of interest that CAR T cells or cell-based therapies can actually give long-term remission in cancer treatment, which is hardly been observed in many of the other modalities. So the basic fundamental difference between CAR T cell or these engineered cells is that they provide long-term remission instead of just a little bit enhancement or incremental survival. Right. So what are these CAR T cells? So CAR T cells is an autologous, that means patient-specific platform where immune cells are harvested from the patient's blood. And these immune cells are taken back to the lab where they are genetically modified. And that genetic modification can be by many different gene delivery vehicles. One of them is lentivirus, which is an HIV-based virus. Another could be retroviruses, nanoparticle-based gene delivery mechanism. Some of you might have heard about CRISPR-based gene delivery, gene editing technologies. Right? So there are multiple ways to transduce or to genetically modify the cells. Once cells are genetically modified, they are expanded in the lab and then re-infused into the patient after certain conditioning chemotherapy. That's how this platform works. And unlike the, as I said, unlike the conventional drug where it is made in bulk and then off the shelf given to many patients, CAR T product, which is currently at least in the market, they are patient specific. So that means every lot is made for that particular patient. And so this is a personalized kind of therapy. There are efforts going on where this also can be made into off-the-shelf therapy, very similar to conventional drugs, but those are still under investigational trial. The FDA approved what is commercially available is a personalized therapy. How the CAR and CAR T cell look like, what is their anatomy? So here in the middle of the slide, you see one T cell. So these are our immune cells, especially the CD3 positive T cell. And the T cell is expressing one receptor, and this receptor is called chimeric antigen receptor. And this chimeric antigen receptor, if you go a little bit deeper in the details, what it has is like any other receptor, it has a extracellular domain. An extracellular domain is basically single chain variable fragment coming from the antibody. SCFV fragment of the antibody, and this is the domain that recognizes the cancer cell. So in the case of CD19 positive B cell tumor, the SCFV is anti-CD19, and anti-CD19 will recognize the CD19 present on the cancer cell. Then you have the transmembrane domain. They have a lot of significant role in terms of the functional efficacy. So each CAR domain is not like a trivial. Every CAR domain, whether it's an extracellular domain or endodomain or the transmembrane domain, they are functionally very important. If any minor change can affect a complete function of the CAR. So in the basic science, there's a lot of effort going on how to design the best CAR, because any modification or any particular domain can have a huge impact on the clinical results of that particular CAR construct. Maybe at some other time we can discuss this, how important the CAR design is. Okay, so what are the different advantages of CAR? CAR, basically CAR T cells, they are live drug. So only one time given, unlike the conventional drug which has to be given multiple times for many months. CAR T is one-time treatment. So the reason why I am pointing out this is because one-time treatment, it may sound very expensive, but for long term, it may be a cost-effective way as well. Okay. So geographical disparity in CAR T, because there's a huge geographical disparity, as you can see from in this particular slide. Most of the trials or the availability of the CAR T is either in the North America or in our neighboring country, China, and some in Europe, but hardly there's anything in South America, Africa, and India. So there's nothing going on in this part of the world, right? So coming to one specific CAR T which has made a lot of headline is CD19 positive CAR T cells. As Professor Santosh was mentioning in the introduction, that CAR T are very successful in the liquid tumor or blood cancer, but they have hardly any good result in the solid tumor. So why in the solid tumor, he pointed out few points, but why it worked very well in the liquid tumor? And why CD19 is the best target? And the reason is that CD19 expression, you see in all the B cell developmental stage, right from the stem cell, once it turn into the pro B cell, till the plasma cell, CD19 is present almost up to the late plasma blast. That means all malignancies originating from this kind of B cell development stages, they can be treated by the CD19 CAR T cell. And because this malignant cells are either in the blood or in the certain organ or lymph nodes, this there's a very good impact of the CAR T, because CAR T can reach to the site and kill the tumor, and that's how you see the good efficacy. Tumor microenvironment or the regulatory environment is not that much suppressing the CAR T activity. Okay. So multiple myeloma, we heard talk in the morning, CD19 is not present in the plasma cells. That's why in multiple myeloma, you don't, the CD19 CAR T do not work. But one caveat is that in certain patients of the multiple myeloma, even CD19 CAR T has shown success. And I think in the morning, the speaker pointed out very important point that maybe this is a heterogeneous disease and there may be some population that express CD19. And this could be the reason why in very few patient subset, even CD19 positive cells work in the multiple myeloma. Okay. So there are many trials happening throughout the world, like right from UK, US to Europe to China, but nothing in India. The biggest success came in 2017 when the Emily Whitehead, who was actually treated for the long back when she was 6 years old, now she has been cancer free for several years, almost now is going to be a decade soon, and she is still under remission. In 2017, the drug was approved by the FDA. So there's now a lot of data came out for the long term, because short term benefit we heard about CAR T, but what about the long term? So if you see the trial coming from UPenn or the Memorial Sloan, what they are showing on the right hand side, that up to the 22 months, if you see the x-axis of this graph and you see the probability, that event-free survival is almost in half of the patient once they cross almost 9 months. So after 9 months, you see a very, very good event-free survival, and this can be last long. indicating in brief that patients can get benefit for the long term. At least half of the patients can have a long-term cure. Similar results published by Memorial Sloan, they have shown that half of the patients who were treated with CAR T as a low disease burden, which is a low disease burden here is a biomarker, as a low disease, they can have a long-term remission of by the anti-CD19 CAR T cells. CAR T cell platform is now growing, not only limited to the blood cancer, it is going in the solid tumor also. There are a lot of work going on, and mostly, especially in the sarcomas, neuroblastoma, glioblastoma, there's a lot of work. They have shown that even in breast cancer, that CAR T might work with certain combinations or certain tuning. In fact, beyond oncology, now CAR Ts are coming for the cardiac fibrosis. And not only CAR T, people are now trying CAR NK, CAR macrophages. So the field of the CAR or the cellular therapy is growing overall. And it is expanding not only in just one disease, but multiple diseases of oncology, as well as even autoimmune disorders. Okay? But as in the beginning, Professor Santosh also mentioned that it's very expensive. Indeed, it's very expensive. And in the US, across the different countries, it's almost cost several crores for one patient. So what are the different bottlenecks in terms of the LMIC, low and middle income countries, as well as India, right? So of course, our cancer incidence is very high, and which I want to highlight here, we have the need, but we don't have the drug. However, other countries may have a very, very low number of patients. Their need is less, but the drug is available. So there's a little bit imbalance between the need and the availability of the treatment. Not available at all in Indian market yet. We recently started the clinical trial, technical and clinical training, because the CAR T is actually very complex manufacturing, and it is a personalized medicine. For every time you have to make for individual patient, there is a huge lack of infrastructure in our country, infrastructure in terms of the facility, as well as clinical training, technical training, etc. Right? And of course, the cost. So how to overcome some of these challenges? Of course, the only way forward is we collaborate, we partnership, and invest in our infrastructure, right? Our efforts in India was, can we reduce the cost? Ultimately, we can bring the cost to 10 to 15 lakh per patient. That can be our ultimate goal. But in the meantime, how we can reduce as much as we can. Right. So for that, can we develop the technology? Can we know how the manufacturing process work? How we can manufacture the best quality product, which is equivalent to anywhere else, and how we can get the novel product. So for this effort, we collaborated with Tata Memorial Hospital TMS team, and we worked together with NCI as a knowledge partner with the Nirali, Periphery, and Stephen Heifel. We all worked together to with this goal to bring CAR T to India. And then finally, we designed a product which has, again, the SCFB coming from the FMC 63. Then we have a CD8 hinge 41BB as our co-stimulatory domain, and CD3 zeta. And we also filed a patent. Our gene delivery vehicle is third generation lentiviral vector, and this work is also published. Okay. Just to give you a brief idea about the animal efficacy data, showing that if you have these Nordic mice, you irradiate them, give them the tumor, NALM6, and then follow day you just give one dose of the CAR T cells, and then follow the tumor growth. So on the left hand side, the lower panel, you see the two the images. One is called control mice. Another is on the right, they are CD19 CAR T treated mice. So on day 11 is the upper panel, the lower panel is on day 18. Sure, I will. How much time I have?
1 minute left, sir.
1 minute. Sure, I will finish it. So day 11 or day 18, what you see in the CD19 CAR T treated mice, they have the low tumor burden. Okay. And this data is highlighted in the American Association of Cancer Research article. Is Molecular Cancer Therapeutics Journal, and we published this work. Nature Biotechnology also highlighted some of our work, that what we have been doing. And after doing preclinical work, the next task was to get the regulatory approval, which is, of course, you all might know that it's a very big task to get all the regulatory approval to do clinical trial. So we got all the regulatory approval, and clinical trials were initiated at Tata Hospital. So we started 2 clinical trials, 2 phase 1. One is adult lymphoma trial. If you want to know more data about or more details about the available this trial, I would suggest in the CTRI website of ICMR. This is open forum, and you can get all the details of inclusion criteria, exclusion criteria. And finally, on June 30th, Dr. Hasmukh Jain treated the first patient. It's too early to comment on the clinical trial data, but we have consented so far 5 patients, manufactured the cells for 4, patients treated are 3. So far, we do not have and no severe toxicity, but of course, too early to comment with this small subset of the data. Similarly, Dr. Gaurav Narula sir, he also started on the June 4th. He treated his first patient on the ALL, pediatric ALL trial. So far, we have consented 3 patients. CAR-T manufactured for 3 patients treated, 2 patients we have treated so far. Again, too early to comment on any clinical data so far. I think they will present the data soon in the right forum, but so far we do not see a very severe toxicity. So our journey so far from 2014, it has been a long journey, so many years, but finally from each step, each year we moved from research related work to translational work. Finally, we have done the clinical trial, and in summary, we can say that this is unique. Is tested in the preclinical work, and now we are doing the patient. We have the patent, and we first do the clinic in India. Other development happening in the lab besides the leukemia and lymphoma, we are going trying for glioblastoma as well as some adjuvant with multiple targets, which can be used for multiple targets. This will come in some future. So how to scale up this work and ultimately commercialize so it can reach to the many patients. So we also founded the company called Immuno, and Carl June, being the father of the CAR T-cell therapy, graciously agreed to be on the scientific advisory board. Avery Posey, who is actually running the lot of clinical trial for solid tumor, he's also in the scientific advisory board, along with Dr. Gaurav Narula, who most of you know him very well. So overall, so my lab here, acknowledgement for the lab people who did all the work. All the work is done mainly by Alka, Atharva, and Ankesh, and Sarvari Ghosh, who is postdoc in the lab. So this is the lab subgroup in the lab who do entire translational work. I also have interest in basic research, which we can talk in another forum, especially in the inflammation side, where half of the PhD students work there. Funding for the translational work for this work mainly came from the Wadhwani Foundation and Tata Trust and IIT Bombay. The funding for basic research I get from government, a lot of government agencies, and of course this work was not possible without the collaboration of Tata Hospital Mumbai, Dr. Gaurav Narula, Dr. Hasmukh Jain, Dr. Panavali sir, Chetan, Naveen Khatri, Dr. Meenal Pujari, and their team members. NIS team helped us immensely, like Terry Fry, Steve Hill, as well as Nirali Shah, and some work which we do in the basic research. Also, we collaborate heavily on the IIT Bombay colleague. And thank you so much for listening.
Thank you, Rahul, for an excellent presentation. I think it's opened up our vistas for the future. So, can we take one question? Any question from the chat box?
So we can take questions during the question and answer session after Dr. Vikram's talk.
Sure, sir.
So I request you to invite our next speaker, Dr. Vikram Matthews.
Thank you. It's my privilege to introduce Dr. Vikram Matthews, Professor of Hematology at CMC Vellore. And he actually needs no introduction. He's a doyen in hematology and one of the finest teachers we have in this subspecialty, and he's going to speak on cellular therapies beyond CAR-T and applicability in India. Over to Dr. Vikram Matthew, please.
Thank you, sir, for that introduction. If I could just share my slide. Okay. Hope you can hear me and see the slide.
It's a little louder, sir, please.
Can you hear me now?
Yes.
Yeah, better, sir.
Okay. So everything pales in comparison to CAR T cells, but I'll try and do my best. Thank you, Rahul, for that great talk, the tour de force. So this is going to be a downer compared to that. Basically, I'm going to talk about other cell therapies in the context of allergenic stem cell transplantation predominantly. And if you look at allergenic stem cell transplantation, where are other cell therapies placed? This is a conventional route that allergenic stem cell transplantation takes. Usually good things happen, but unfortunately in the context of malignancies, majority of patients relapse. And there are possibilities for various cell therapies to decrease that risk of relapse. We have various infections post-transplant, especially in the haploidentical stem cell transplant setting, where we need therapies, which many of the drug therapies are extremely expensive, and viral cytotoxic T lymphocytes are extremely effective. And there are different strategies for that. We also do graft manipulation to decrease the GVHT with alpha-beta depletion. All that is highlighted in red is what we do. But what I'm going to be talking about is predominantly, for the time constraints, on NK cell-based therapy, viral CTL, and CD45RA. And I'm just going to talk about a little bit of what we do. At our center, based on our predominantly allergenic stem cell transplantation background, where we do about 250 transplants a year, and what you can see over there in the purple is the number of haplotransplants, which has significantly increased. They come with their own significant challenges, and we need solutions which are indigenous and local that can apply to these patients, and I'll talk a little bit about them. Most of our work is done in a class 10,000 facility, and the studies that are ongoing are a TCR alpha-beta depletion study, a CD45RA depleted prophylactic DLI, viral CTL work. We have a CMV CTL study that's ongoing. We have an optimized NK cell study, which we have just finished the first part, and we're going to the second phase of the study. And our CD19 CAR T, we finished our validation and manufacturing processes, and we are waiting approval for the clinical trial. So most of our manufacturing, I'm not a vector biologist like Rahul Punwar, so we depend on people for vectors, etc., from others. But we do our manufacturing of our cells in our own facilities. And I'll start with the NK cell-based therapy. Again, for this audience, which is a very focused audience, all of you all understand this biology and the relevance of NK cells, and that they were recognized and they've been utilized to kill malignant cells, predominantly by the fact that many of the malignant cells have downregulation of most of the HLA molecules. It's part of the innate immune system, though recent data has demonstrated the ability for long-lived memory cells with the ability for recall response, and that is something that can potentially be exploited in the setting of acute myeloid leukemia. A fundamental problem with NK cells has been generation of large number of cells that are required. And this is the conundrum often that one faces. When one does do massive expansion of cells, you tend to lose cytolytic activity. And this has implications on how we go about it. And this is because of a process called licensing. NK cells become functionally competent only after they encounter self-HLA molecules. And this ensures that they are self-activated only if they have the ability to recognize self. Implications of this in vitro expansion is something that we and others, and there's already a lot of published data on this, we continue to work on this. So there was a lot of initial hype about adoptive NK cell transfer. Many of them has not held up in time. But I think there are small additional increments which one cannot ignore, and there is a renewed interest in this area. Some of our basic science observations was in an earlier study when we were looking at immune reconstitution following ATO, we found, unlike our transplant patients, there was a significant delay in the recovery of NK cells. When we further studied this at mechanistic level, we found that arsenic trioxide actually decreases biogenesis, but actually enhances the efficacy and the cytolytic activity of NK cells. So this is, I'm not going to go through this data in detail, it's freely available online, but basically when NK cells and malignant cell lines are exposed at very low concentrations, way below the therapeutic concentrations, the receptor ligand profile in the malignant cells and the NK cells is shifted in a direction which enhances cell kill. And we thought we'll explore this in a preliminary phase 1, phase 2 trial. There's data already looking at the use of NK cells in patients with AML, looking at peak cytopenia infusion of NK cells from from an alternative haploidentical donor compared to the main donor. And this study from example in MD Anderson showed about a 30% long-term survival, which in a setting of a relapsed refractory AML is actually not bad. So this is great, basically the trial design that we had. This is a study which was funded partly by Wellcome DBT. Uday Kulkarni, my student, is an early career fellow. Basically, we take patients who are relapsed refractory and in peak cytopenia after their initial conditioning or the initial chemotherapy, we infuse NK cells for 7 days and then follow this up again in peak cytopenia with a Flumel transplantation. This is a strategy many of the transplanters are aware of in this very difficult group of patients to treat. And with this approach, without getting into too much of the technical details, we developed an algorithm on how we'll choose the haplodonor for the NK cells, where we go for PSA negativity as high priority, followed by a key ligand mismatch, followed by the key P haplotype score. And a combination of this gives us the optimal donor that we would like to have for the NK cells. And basically, what we've done is we've treated about 1 patient with true consent. Of the 13 patients that you are seeing here, you can see that we had about a 30%, close to 30%, 28% long-term survival. This study is not designed for efficacy. It was predominantly designed for safety. And we're using this platform to further expand on the next phase of the clinical trial, where we are moving it up into first relapse and high-risk patients. We can actually track these NK cells after infusion by, especially when we have antibodies where the HLA antibodies are different between the donor and the recipient, and antibodies available. So for example, here, the donor and the recipient are different on the A2 antibody. So you can see the chimerism. There is a mixture in the donor and the recipient in terms of the NK T cells, and the NK cells, but you can see the T cells are all recipient. So what is shown as A2 negative are actually the donor cells. This is on the day of, on day 3 post-infusion. So we can actually track the NK cells, at least in some cases where we do have antibodies to track them. CD45RA depletion. So what's the story here? So here what we're trying to do is exploit the fact that this is a technology that's already available, where CD45RA is one of the isoforms on CD3, which is expressed on naive T cells. And so conceptually, when you infuse and create GVHT, it's the naive T cells that can create GVHT. While if you remove that population, and that's the hypothesis, the remaining cells are already exposed to antigens and are committed cells, which cannot cause GVHT, but they will only attack antigens that they've previously seen. So if you take CD45RA depleted cells, they could potentially act against viruses, etc., which people have seen. And this is a major challenge in our haplotransplant program, where we have significant CMV reactivation and BK cell reactivation. And most of our population, as you know, is 98% serology positive. So all of us probably do have T cells that have seen CMV, and for that matter, BK virus. So here you basically take a haplodonor, and I'm not going to go into the gating strategy, just focus on this. This is the CD45RA population. We do it through an apheresis, we take it through a prodigy system, and we deplete it, and you completely lose the CD45RA. And the strategy after that is that you can actually take these cells from just a small component of the original graft. Just an illustration over here. If you have a 260 ml PBSC, you may infuse the amount of CD34 that you need, and the remaining cells can be taken to generate the CD45RO cells, which are then put into aliquots and cryopreserved. And the concept is that post-haplotransplant, you can have delayed immune reconstitution, increased risk of viral reactivation, and CD45RA depleted add-back could potentially overcome some of this without giving you the risk of graft versus host disease. And this, in summary, is the template of the study that is currently ongoing and recruiting patients. There's been some changes in the dose, but basically after infusion of product around day 5, we give aliquots based on certain predefined criteria that the patient must fulfill at each time point. Viral specific cytotoxic T cells, you can do it via a cytokine capture system, which already is well used in the world in the prodigy system. We also have an in vitro expansion of viral specific T lymphocytes, and this is something we are more excited about because this can reduce the cost of a viral specific T cell down to less than 1.5 lakhs. And this has huge implications for our transplant program. We already have this standardized, and we the cytokine capture system. And when you do the cytokine capture system, you usually screen 1 to 3 donors, and you take the donor you expose a small aliquot of his cells to pep mix of the particular viral, CMV, BK, or adeno, in this case CMV, and you look for the CD8 interferon gamma response in his T cells. And then you take the donor which has the highest CD8 interferon gamma population, and we usually target at least a percentage of 1% as much as possible. And that's the person we take onto the apheresis, and then we apheresis and take the cells which are magnetically coated, magnetically targeted to be removed, that is the interferon positive cells. And what I'm trying to show here is a complex gating strategy. All I want you to focus on this point. This is the the apheresis sample showing the naive population. And after you select your population, you have no naive T cells. So the cells that you select, the interferon gamma positive, are all committed cytotoxic T lymphocytes, which have already probably seen CMV antigen based on the PET mix that you exposed them to. And so this is our preliminary data. Using this approach, we can generate fairly large number of cells. We've infused many of them early in the day to really comment on efficacy, but a number of patients have received this. This is a very crowded slide. I don't need you to walk through this. All I want you to say, what I showed you was data with the cytokine capture system on the Prodigy, but a much lower cost, which has to be done in an open system correctly in our facility. And therefore, we will need significant approvals before we can take this to the clinic, is a manual open expansion of viral specific T lymphocytes. And for this, we have done our preliminary validation runs, and we can get anywhere between 4 to 21-fold expansion of cells adequate for therapy. So I'll just conclude this part in the interest of time and say that cell therapies beyond CAR T cell therapy are feasible, and I would say they are very applicable, especially considering the number of transplant centers and the significant challenges we face. And these are therapies that can significantly address these problems, potentially in a cost-effective way. All of us who deal with transplants know the financial toxicity of the complications that happen after transplant. So if you can reduce the risk of relapse, even by a small margin, and reduce viral reactivation, the benefits could be huge. Of course, there's an era of constant technological advancement, and I'm sure many of these technologies will further improve, and the cost will also further improve. I'll stop here. I'd be happy to take questions. I, of course, have to acknowledge many people in the department who work hard, but the key people who work in the area of cell therapy is Hemant and Arun, Viju, Uday, and Anu, and a whole lot of other staff. There are too many to acknowledge over here. Thank you for your attention.
Thank you, Vikram, for the excellent presentation. Are we going to take questions now? I guess in the chat box there are some questions.
Sir, I would like to invite our lead discussant, Dr. Vivek Radhakrishnan, sir, who is hematologist, oncologist, and BMT physician, senior consultant and attending physician at Tata Medical Center, Kolkata, for the question and answer moderation. Over to you, sir.
Good morning, everyone, and thank you to the IOSI meeting for giving us this opportunity. And thank you, Professor Purwar and Vikram, sir, for that excellent talk of their original work. So the theme of this conference is choosing wisely. So I would first ask Professor Purwar, as a basic scientist who has taken something from the bench to the bedside, what is your advice to budding translational scientists in this field as to how to plan wisely to take these concepts to the bedside? Because there are a lot, you have seen it all, right from the conceptual stage to taking it to the clinic. So what is your suggestions to the budding scientist?
Thank you, Dr. Radhakrishnan. Honestly speaking, I am still learning. So I don't think I am still the budding scientist only, because, you know, I am still like in full working mode all the time. So I don't know if I am still eligible to give advice to anybody, but I can tell you it's been a journey. It's been like a lot of work and lot of things to manage with besides work. So I'm still learning, I think. So advice to everybody in general is that keep doing it. I think one day it will work. Only thing is persistence, and keep asking for help, keep collaborating, because collaboration is the only way forward in this country. I can tell you, alone you can't do anything. And Like I always keep writing even email to Dr. Vikram sir and everybody, like everybody possible. So I think most of you, even if sometimes tired of my mails and my help, asking help. So don't hesitate. Many times 1 out of 100 it will work. But if one person comes to your help, I think that is good enough.
So Vikram sir, for a clinician who is planning to bring CAR T cell therapy or any cellular therapies to the clinic, you had hands-on experience in bringing the NK cell therapy to, some conclusion in terms of this trial that you are recruiting currently and the experience that you have. What were the pain points that you experienced, and how do you think that a clinician who wants to bring these cellular therapies to the clinic should maneuver it through?
I think a lot of it, to some extent, it also depends on the environment you are and the amount of support that you can get within your institution, within your peers, etc. I think it's never an individual, it's always a group of people. In addition to that, I think you have to persevere on some of these things, because there will be ups and downs, and there'll be always people questioning what is the relevance of this, and when everything else is so expensive, etc. But I really feel it's very important to stay on top of technology for the sake of staying on top of technology. Because, I'll just take you back to GCSF. When I started, one dose of GCSF used to cost a person's salary. It was that expensive. We all know our experience with biologics. But as more and more players come, as more and more expertise develops in the country, I'm very confident that these therapies will become more and more affordable. And so I think it's very important to stay focused and stay on it.
So you work on an automated system like Prodigy, and Professor Purwar works on a semi-automated system. In terms of what is practical for a hospital which wants to start cellular therapy facilities, what would be your advice?
So my bias would be a closed system, and that's my bias. I start with that statement. I think what I would like to see is every center to really decentralize manufacturing. Vector manufacturing is a completely different ballgame. Only Rahul can answer that question. That is the level of complexity that requires industrial involvement. But to truly get it accessible to a country this large, you cannot have one or two places manufacturing and distributing. I don't think that model will work. It will be expensive. It cannot be purely industry driven as well. I really, really feel that all big centers, basically, if you have a reasonably good transplant unit, you should be able to, we are all used to working with cell products in our transplant program. So we understand this to some extent, but there is another level that has to be done. So my system is to go for a closed system. What we today have is just the Prodigy. But remember, there are many people working on better, cheaper systems which could potentially have greater applicability. That's my hope for the future.
So, Dr. Purwar, your question is, what are the regulatory features of getting these cellular therapies to the clinic? Do you find it facilitatory, or do you find that regulations need to be very adaptive to the realities of India?
So I will answer both the questions, the previous one as well as this one. So the previous one you asked about the applicability or the feasibility of the closed system versus the semi-automated system. I think both systems are good. It depends on your requirement. For example, if you are a low volume center, then you might, for example, country like Cuba or Croatia, they treat only 1 to 2 patients a month. If there is that kind of demand, it doesn't make sense to have a facility which can cater even 30-40 patients a month. So again, it will come if your center only has 1 patient or 2 patients in a month, maybe a closed system, which even expensive can help you. But for the larger volume center, or if you really want to make therapy affordable, then probably you would need a facility which can cater many people. So this is the logistic wise is my preference or my opinion. Regarding regulatory thing, I think regulatory is also evolving. We all are learning. Manufacturing, as Dr. Vikram sir said, that is expensive today, but maybe in next 10 years, it may be affordable also. It would be less expensive. Similarly, manufacturing, same way, I think clinic and regulatory, we all are learning in this genetic engineering or genetic engineered cells. So I think regulatory is very acceptable. They listen to us, and if there are something need to be done, I think they get convinced also. So I would say the environment is good. At least people are listening and people are reacting to it positively.
There is one question in the chat box where Professor Girdhari Lal has asked you a question as to how do you boost the effector immunity to have anti-tumor activity with minimal toxicity? Is it the number of immune cells in the adoptive transfer or the fitness of the cells in the adoptive, cell therapy mixture that you have prepared?
So it's a very good question. It depends actually, or in fact, it directly correlates to both the things. One, your exhaustion of the cell or fitness of the cell should be good. Exhaustion should be less. So fitness of the cell has a huge role in the ultimate efficacy in the clinic. If you give a person many cells, but they are not fit, they will not persist long, and ultimately you will lose the response. So fitness of the cells is very important. And that's the reason, in fact, the Zuma trial or the other trial data just came out showing if you give CAR T little bit early, in the not the second line or not the third line, if you get slightly early, then you may have a better result in the clinical in the clinic. Similarly, I think dose of the CAR T is also very important. In the morning, we heard a study of the BCMA trial, and it was clear that higher the numbers are given, better the response was, and it was persisting longer, and the long-term response was very, very good if the number of cells are slightly higher. So I would suggest both. The good quality cells should be there in your product, and enough numbers should be there.
We are running short of time, but there is one more question in the chat box which I would request Professor Vikram to answer. As in, with the unique toxicity profiles of cell therapies, that is CRS and the ICANS, what should a clinician be prepared with in terms of handling these unique toxicities?
I think that's a great question. And so often the entire conversation on CAR T cells focuses on vector production, CAR T cell, and outcome. But what is not said, and what most centers that are practicing abroad, is there's a whole team of nurses and medical personnel, technicians, who have to go, and ICUs, who have to go a fairly intensive training process to early recognize complications and toxicities and intervene early. So Vivek, you'll certainly understand as a transplanter, picking up GVHT very early is very different from missing GVHT early. And the same goes for any of these toxicities. The earlier you pick it up, the more the successive chance that you will salvage the patient and not miss it. So I think there's a lot of training. I can't say we are there yet. Right now, it's theoretical training for us, but down the line, we have to start somewhere. But you'll have to train not just your medical team, you'll have to train your whole nursing team and a whole set of technical team as well to deliver this therapy effectively, which is what I've been really working with many of the funding bodies to say that it's not just about starting something. You need to train a whole lot of people. And that's why we need to do more of this in multiple centers, to really get this going in the country.
I completely agree with you on that, sir. On that note, I thank the organizers for giving me this opportunity. I will sign out with, I think Dr. Hemant, our president-elect, has one question. I would request him to ask the question, and on behalf of the organizers, I thank me.
Thank you, Vivek. I thought in the interest of time, my question is not going to be addressed. One quick question. So my congratulations to Rahul and the team at Tata. Rahul, if everything goes well, there is nothing untowards in the clinical trial. Very short answer. When do we expect Indian CAR to be available off trial to the Indian patients? Quick answer. Tough question, but quick answer.
So if all goes well, sir, 1.5 year, it may be approved for at least emergency approval yeah, that's what we are hoping if we get it from the DCGI.
Coming IOSI.
If I may say one thing, Rahul, as soon as you produce it, we'll be very happy to use it as well. With, of course, working with you on it, with the vector.
So
Many
I
of
wish
us
to
are waiting
extend.
for it.
Sorry, I wish to extend my sincere thanks to Dr. Rahul, Dr. Vikram Matthews, chairpersons, and Dr. Vivek, everyone for this excellent brainstorming session. And in the interest of time, we will move fast to the next session. Over to you, Rekha.
Thank you, Dr.
Next session, I would like to invite our chairpersons, Dr. N.K. Mehra sir, who is founder head, Department of Transplant Immunology and Immunogenetics, All India Institute of Medical Sciences, Delhi, and Dr. Sunil Arora sir, who is president of Indian Immunology Society and head Department of Translational and Regenerative Medicine at PGI MER, Chandigarh. Over to you, sir. I request Dr. Mehra to provide the session introduction. Over to you, sir.
Thank you very much. At the very outset, I would like to thank Jyoti Bajpai, Atul, and Amit Awasthi for giving me this opportunity. I think it is becoming very clear that immunotherapy holds immense promise to treat the various types of cancers, most specifically the difficult to treat blood cancers and solid tumors like the lung, as well as many more. And the goal here is to extend people's longevity and the quality of life. And the recent studies have shown, and you have heard from Rahul, that the CAR T cells are becoming very important. I want to also focus on the CAR NK cells. Vikram talked about the NK cells as well. I myself am very fond of NK. My own initials are NK. The CAR NK cells have high specificity and efficacy, leading to more spontaneous killing of the tumor. They need not be HLA matched for any anti-tumor efficacy, and billions can be expanded and activated from a single source in a matter of weeks. Further, I know that these cells lack memory, and this will not, and thus will not expand uncontrollably in vivo. They have modest toxicity, which means the repeat dosing can be done. The therapy at the moment is in a very developmental stage, as we have heard, and Rahul said it will take about 1.5 years. Globally, there have been intense research efforts are being made. We need to bring all these products in India, both the CAR T cells as well as CAR NK cells, conduct those initial pilot studies, and eventually establish manufacturing capacity in the country. And that will bring down the cost on one hand, and also make sure that it can be given to everyone else. So I think this seminar or this symposium is being held at a very appropriate time to discuss about the immuno-oncology research being carried out in India. Thank you very much once again.
I request Dr. Sunil Arora sir to invite the speaker. Over to you, sir.
Okay, thank you very much, Dr. Vajpai and the team, and Amit for asking me to introduce the next speaker. It's my honor and pleasure to introducing Dr. Girdhari Lal, who is a close friend and associate with me in the Indian Immunology Society Executive, because he is our vice president from the Western Zone, and we have been working together to carry forward the message of society using various platforms. And I have found him really competent. He's one of those young breed of scientists in India who is doing cutting edge research in the basic sciences, where he is using his lab in NCCS Pune, which is interested in understanding the cellular and molecular mechanisms of immune tolerance. His laboratory is investigating the role of neuroimmune communication in autoimmune autoimmunity, and cancer. He has published 50 papers and presented his work in various national and international meetings. He has received several national and international awards, including Ramalinga Swami Fellowship and Innovative Young Biotechnologist Award from the Department of Biotechnology, and lately Swaran Jayanti Fellowship from the Department of Science and Technology, Ministry of Science and Technology, the Government of India. So today is decided to talk on current status of immuno-oncology research in India with challenges and remedies. And I look forward to listening to his great talk. So over to you, Dr. Girdhari Lal, and the platform is for you. Thank you.
Thank you, Dr. Aura, for a very kind introduction. And also let me start with thanking Dr. Jyoti Bajpai and Amit Sharma and Dr. Amit Awasthi for putting all this together. Let me share my slides. His slide is visible?
Yes, sir. Just full screen.
Okay. All right, perfect. So I was asked actually to talk about current status of immuno-oncology research in India, current this remedy, and what are future challenges. So what I'm going to do, we have heard a lot about the checkpoint inhibitor, and also Rahul and Dr. Mathu has put very nicely what is adaptive cellular therapy, especially on NK cell and CAR T cells. And so I just took off those slides. I think they explain much better. And also I apologize for some of the things which I may not able to include some of the research which is going on, especially nanobiotechnology and anti-cancer research, including the immunotherapy, related with immunotherapy. All right, so whenever we talk about cancer therapy, we know that variety of ways it can be treated. And now we know that these divisions are actually interlinked, and the interlinking is required because if you look at this graph, how we can make these changes, this particular graph wide in order to have the better the effect of immunotherapy. So now we know that the chemotherapy combined, immunotherapy combined, radiotherapy, whatever we do, what is interesting here, that if you look at that, there is sharp plateau here. So a lot of patients actually just give up. And those who tolerate, now including all this combination, where we are looking at how much actually statistically significant or not. So we need to also worry where this graph is falling, how best we can combine any of these therapy to have this particular longevity or area under curve much better. All right, so what I'm going to do, all right. So let's start with just, we know a lot of all these things. What I want to point out here is that when you have a tumor, when you have immune reaction, you have APC or antigen presenting cell goes back to the lymph node, and they get training, and then the T cell response are generated, they circulate, migrate, come back to tumor, and that's how anti-tumor immunity you see. While doing this, while the cycle goes on, there are a lot of molecular interaction and cellular interactions. And each one of these cellular interactions are very important. And if you try interfering with any one of them, you see that in the literature that people try to interfere one by one or combination, variety of ways, either to promote anti-tumor activity or in the molecule which are checkpoint inhibitor we discussed so long in this meeting, that any of these, if you block it, you get the effector immune response. Essentially, you're rolling around how to work out better anti-tumor therapy. So all these molecules which are in red, you have to actually negatively regulate. The other one which are in green, you have to promote them to have better anti-tumor immunity. Now let me take just quick example of dendritic cell among them. The dendritic cell takes antigen presenting cell, the antigen from the tumor, T cell are formed, then it goes back to tumor and all these things going on. So that's how it was thought. And that's how this actually the dendritic cell trial has been done in this country, even in this country. There are a lot more trials across the globe, but I'm putting some of them, which is here, that you can see that the APEC Biotech Private Limited, Gurgaon, I think they have done the dendritic cell vaccination, and there are several other laboratories and hospitals which has done. And you can see they have just take the PBMC and monocyte-derived dendritic cells, which express all these markers, and you see either combination, they actually work better, perform better. And now there are molecules, there are the antigens, which actually when you treat them, dendritic cells, they also perform where one of these molecules, Dr. Anil Suri's lab from NII, and then with the collaboration, this work has been done. Now question is, how do we figure out which antigen to feed when you have to feed the dendritic cells and then adaptive transfer? So there are a lot more the theoretical or the computational knowledge need to be learned, and then you combine that to understand who is fit. And that's what we had this morning discussion about neoantigen, how to figure out and which neoantigen, how many neoantigen to have the anti-tumor therapy. I think on that line, I just want to mention that from our center, National Center for Cell Science, Dr. Samila Bapat is also looking at the neoantigens in ovarian cancer. I think she has very interesting finding. And we will see that how to lead from there what she had. Now you have antigen, you have dendritic cells, and this cycle has to move on to have effector function. Now we heard that there are anti-tumor therapy checkpoint blocker. Where it happens, what is the contribution of nodules, what is contribution of tertiary lymphoid organ further than this is required. So very quick example, in this experiment, this is the adenocarcinoma cell line. If you remove the tumor, and then you do checkpoint blocking therapy, does it work? Do you require the secondary lymphoid organ in time? So what you saw that the anti-tumor effect function, what will happen in the tumor? Probably not. So if you remove this tumor, the nodules or lymph node, draining lymph node, the checkpoint inhibitor activities drop and the survivability is also drop, suggesting that you require tertiary lymphoid, secondary lymphoid organ. And in clinic, when you look at the tumor, depending on the grade of tumor and the type of tumor, you will have secondary lymphoid organs or tertiary lymphoid organ formed. You can see that B cell, T cell, a composite structure, which is here close by, and you zoom here and you see that the structures are formed. And especially if you look at those structures, the outcome turn out to better, especially with checkpoint inhibitor. So now we need to figure out, we need to understand whom to give and what kind of tumor. Or do we really require to promote the tertiary lymphoid organ along with checkpoint inhibitor or any other immunotherapy? That if you have the more tertiary lymphoid organ form, probably your efficacy will be higher. So NK cell is already talked, CAR T cell is already talked. So gamma delta T cells is also important, which Dr. Matthew mentioned on. And also there are a lot of things we can actually has been done across the globe. And I think Dr. Chuplankar in India is one of the key person to work on gamma delta T cells, and she may tell you much more story better than me that what goes on in gamma delta T cell. And I just wanted to put one thing, not much actually, I didn't see much progress on adaptive cellular on this gamma delta, but one of the findings which I see from the Syngene International Biotech that develop antibody which actually work on gamma delta T cell and promote anti-tumor activity. Abscopal effect, where the radiation and chemotherapy or the immunotherapy is combined. So you irradiate one and then irradiate a particular site of tumor, and you see the degradation of tumor at distal location. And that's interesting area. And if you look into the country, there are a lot of trials has been done, and also now radiation therapy is improving, and now we have proton therapy, proton beam therapy, which is much more focused and it doesn't have very, very long the deep tumor effect. And Jyoti already mentioned that you can combine the immunotherapy and radiotherapy, you have better output. I think I have much more hope that it might work out much better strategy to combine the radioimmunotherapy and the immunotherapy. Now, gut microbe the bacteria and host interaction, we heard that from Amit's lab that there are bacteria which produce a lot of molecules which are carcinogenic. Now, these are the bad bacteria. Now, in order to have this, what is the interaction and how we can feed on the bad bacteria? One of the example was shown just by sodium chloride, it alters the location. Likewise, we have to see that how to get rid of this bad bacteria which is producing carcinogen and participating in the cancer immunity. Now, whenever we talk about how to handle it, so we know that when we pump this immune system effector function, you see that neurotoxicity, endocrine toxicity. If you change this, you will see that immune system is dysregulated and endocrine is also affected. So there has to be a tight balance. How to keep this balance? We need to learn this so that we can actually avoid some kind of toxicity, because toxicity is not from just one end. It actually disbalance of all these regulatory network what we have, which is complex. Now gut. Gut is very, very important organ, and you see there are a lot of nerves and a lot of the immune cells, almost 80% of your immune cell in the gut. So if you're thinking about immunotherapy, cannot be ignored. So the immune cells, toxicity, and the over and all gut microflora makes very, very complex. So what I wanted to point out, there is nerve, which actually neuronal signals, and there are immune cells, which immune signals. And if you look at both of them together, the nerve cell express the molecule of immunological interest, and immune cell also express the molecule of neurological interest. Like I'll take one example. Serotonin. Serotonin is produced in the gut by gut as well as in the brain. And now you have the function of serotonin in the gut. We know that it's a happy hormone, keep you happy. But now where it works, how it works, what it does in terms of immune reaction, that's very interesting area and challenging area. And what is role in anti-cancer immunity? Now, if the receptor, which is expressed, the bind the serotonin, there are variety of them, and variety of cancer type express variety of these receptors. So we were wondering what to make use of this. And to that line, we started looking at, because now there are a lot of data available in TCGA and also the survival of the patient, we just asked question, okay, just look at all the receptors, characterize patient who had based on the TCGA RNA-seq data, that two group, one which has higher expression of these receptor and one which has lower expression of receptor. And now to see that, does any of these patient of two category have any survival benefit? So when we started looking, none of them these shows, but we were surprised when we see one of these receptor called 5-STR2B. Whenever there is the higher expression, the patient which has higher expression, the survivability of that patient actually goes down. So now when we started looking at in the laboratory, that if you take the colon biopsy and look at this receptor expression, you see that the colon tumor, the colon adenocarcinoma patient has much more higher expression of this receptor. And also you can see that the enzyme which is required for serotonin synthesis, that also are very high expressed in this adenocarcinoma. So what? So if you answer so what, so we went to mouse to see that how the mouse respond to. So here is a mouse colon cancer cell line. And you see the tumor grows when you give the injection, and now you come back a different grade of this tumor, and you see that this receptor is increased as the severity or the grade of tumor is increased, so as the enzyme required for synthesis. Okay, fine. So when we thought, okay, what is use of it? So we just actually antagonize this receptor. We did a lot of experiment. We're not showing the data in interest of time, but we just focus on this particular receptor. You antagonize this receptor. Now you see the tumor stop growing. And the experiment was done that you inject the tumor, let the tumor grow for 7 days, don't interfere anything. After 7 days, you come back and start injecting this, the antagonist. Now, if you agonize this, you see that tumor is growing, and we know then depression and psychological therapy, there are like serotonin inducer or reuptake inhibitors. If you do that, if you increase the serotonin content in periphery, you actually see much more tumor growth. The data is not shown here. Now the question is, how does this is working? Is it working on tumor cell? Is it immune cell which is controlling this? So to do this, what we did actually, we used NRG mice, which lack T cell, doesn't have its B cell or even NK cell. Now this mice has very disrupted the immune system because TB and NK cell are missing. Now, if you do the same therapy and do that, now mice doesn't respond. So obviously the question is that it is responding through immune system. Now question is it the tumor directly to segregate that part? The experiment was done here is that you take a mice which you treat with the antagonist, and now, or you transplant tumor and give the agonist. Now take the immune cell from here and inject this immune cell in NRG mice which does not have immune cell of its own, and transplant tumor and see what happened. Does the mice which has this particular tumor and antagonist, how does behave? And now you see that whenever you have tumor and then the antagonist treated immune cells, not even directly drug, these immune cells are sufficient to protect the mice. You keep on doing the immunology, great work, looking at more molecular detail and cellular detail. What you see here is the tumor Disney plot where you're seeing that PDL1 in black color. Now you just antagonize this. There are two antagonists used. We have used others as well. Now a black line is missing. Somehow controlling the PDL1 expression, that's one. There are several other components involved in it. I'm not showing the data. You can also combine the immunotherapy like medical one with this, so that you can low dose of antibody, and especially in India, we cannot afford, we discussed several times this. And if you do that, very, very suboptimal concentration now tumor, and this particular combination actually works one fantastic. Even chemotherapy you can combine, it also gives effect that chemotherapy in combination, you see the green line and this light, this color actually both are in the bottom of the x-axis. There are other cellular phenotype. I'm not going in detail. Now coming back to quickly on the personalized medicine, whenever we talk about personalized medicine, especially in Indian context, is actually difficult to afford by everybody. Although we are doing very good research on that, there are a lot of people are involved in. We need a system where it should be personalized and it should be reached to the people of our country. So we need a system. We need to use biology in a way that it should reach to the people where they need. So on that line, what I was asked, actually, I showed this data last year, but I had several now updates on it, that how do we adaptive cellular therapy where you don't require complex laboratory, but still you should be able to personalize to the patient and use very, very suboptimal concentration of the disease. So our legal team and IPR team said that you cannot show this data at this meeting, probably in the next meeting. So I'm just telling you, because of excitement, you can see that this I'm labeling as cell A, which is tumor-derived cells. Now, if you have cell A, which is coming from tumor, you see that it is suppressing the tumor. Now, you can test it. You can test in variety of tumor that if you have various type of tumor, where does it work? How does it work? I think that's a lot more to learn. So I will actually say the question, the problem in this, that how much inflammation we require. And how much when I say, that means you have not only just interferon gamma, there are a variety of cells, the effector immune cells, there are a variety of cytokines. Which one? Why we focus on one or two? Why not think of others? Because what in biology happen is a complex. It actually probably have requirement of all to balance the homeostasis, which I mentioned to you, that all the three are. And what kind of inflammation is enough? And where do we need these inflammatory reaction? In the secondary lymphoid organ, in tumor, or in somewhere else, or we need to promote the tertiary lymphoid organ? I think a lot more things we need to learn to manage toxicity, as well as to optimize our therapy to area under curve, what I showed to you should be managed to look much better. How are different regulatory network are disturbed with immunotherapy? I think this requires little more thinking, that to our toxicity, how we manage all this disbalance of these regulatory elements, and who is responsible for toxicity and neurotoxicity. So that's another area. Like we saw that there are a lot of cytokines are released, a lot of other molecules are formed. Is all of them are bad? If some of them are bad, we need to focus on who are the one which is bad, and we should take care of which help us to manage the toxicity. And among the cytokine, like I said, the neuroimmune communication, there are cytokines which really talk to neurons, and they have capability to move around. And they are not necessary all the time to be there, but they are formed as a byproduct. So the data which I'm not showing, but we need to understand that who are they and how they are important and where they're important. I think that's an interesting area. And I will close my talk here. Thank you very much.
Now I request lead discussant, Dr. Sandeep Singh, who is Associate Professor from National Institute of Biomedical Genomics from West Bengal, to moderate the question and answer session. Over to you, sir.
Thank you. Thank you, organizers, for giving me the opportunity to be the part and giving me this important job. So congratulations, Dr. Giridhari, for summarizing in such a short time. You summarize all the research which is basically being done by Indian researchers in the field of immuno-oncology. You have very rightly pointed out that adding small molecule inhibitors which you have used in your research will actually reduce the cost, may also reduce the cost. So I don't see a lot of questions here. I will start with Dr. Rahul Purwar's question. How is cell A, which you have proposed, is generated? can you elaborate a little bit? I don't know whether how much possible it will be for you to elaborate on that, but can you please try?
Right. So thank you, Rahul. I think everybody's curious, and I'm also excited to actually unfold this story much better way. But at this moment, I was told actually not to discuss much on it. But probably in the next meeting, I will come back and tell you more detail about it, and probably to discuss more about why and how does it personalize to the particular patient. Why actually we should call it personalized rather than just a total kind of like individual cell type.
Sure. Thank you. So this may be the question for a lot of young scientists like you, me, and many more, which are non-clinical researchers. So in your opinion, a non-clinical researcher, how difficult or easy it is to talk to the clinicians and take your research to the clinic? Will you be able to?
Yeah, so I will say that look at this forum, the best forum you have, especially if you are working in area of cancer immunology, or so I think this provides this type of particular society provides best forum that now you have interactions with the different people, different clinician working in different area of cancer, and then probably that's best platform to start or begin with.
Yes, so my comment on this will be if we increase the involvement of the industry representation also in this kind of forum, so that we can actually scale up our research to the level which is actually required to cater so many patients in India. So thank you, and I will, in the interest of time, I'll request organizers to take and suggest.
So thank you very much. Indeed, this was a wonderful session, Dr. Girdhari Lal, and we will be curious to have your elaborations in the upcoming IOSI on these discoveries. Thank you very much, Dr. Singh, for this excellent discussion and well in time. Thank you, chairpersons, for your very valuable inputs. And we'll move on to the next session. Over to you, Rekha. Thanks a lot.
Thank you.
Thank you, sir. So we are moving to a last session of third annual Congress of IOSI. I would like to invite our chairpersons, Dr. Sumit Gujral sir, who is Professor Department of Pathology from Tata Memorial Center, Mumbai, and Dr. Reena Nair ma'am. She's Senior Consultant Clinical Hematologist, Head Department of Medical Oncology at Tata Medical Center, Kolkata. Over to you. I request Dr. Gujral to invite the moderator.
Go ahead. Yeah, hi, Ms. Thank you very much for having me here, Jyoti and the team. I won't waste time, and I request the moderator to, moderator is Manju, and Manju to come and take over. Thank you, Manju.
Thank you, sir. Thank you, sir. Thank you, the organizing team. And we have an interesting, though the last session of the meeting, and it's focusing on advances with respect to immunotherapy in field of hematological malignancies. My panelists are Dr. Smita Kayal, I think Smita is here, Dr. Lingaraj Nayak, Dr. Hari Menon, Dr. Vipul Sheikh, Dr. Hemant Malhotra, Dr. Gaurav Narula, Dr. Samir Bakshi, Dr. Lalit Kumar, and Dr. Pratesh Jain. I'm not sure Sir has joined, Dr. Lalit, because he was facing some internet issues. That's what he messaged me some time back.
Yeah. We have spoken with her, ma'am, and he's just joining when the technical glitch is resolved.
Yeah. I'm not sure if Pratesh is around.
He's joining.
Great. So I'll just share my screen. We have a mix of panel of, adult medical oncologists as well as pediatric oncologists. So what I'm going to do, I'm going to have questions which are, focusing mainly the age group, which is adolescent and young adults, as well as the older adults. That's what I'm trying to do. I'm not going to present too much data because I have a very eminent panelist group here who's going to, discuss the data in great detail for all these questions. So it's going to be mainly case-based scenarios, what I'm going to talk on. So with that, I'll just start with the first case. And so this is a 20-year-old female who's diagnosed with classical Hodgkin's lymphoma. At presentation, she had stage 4B disease, predominantly bulky mediastinum with the IPS score of 5. And she gets treated at the first presentation with ABVD, first 2 cycles, interim PET in complete response, and then it was changed to AVD, and she remains in complete response. However, unfortunately, a year later, she presents with recurrence in the neck, mediastinum, and splenic lesions. And even at this time, the biopsy is consistent with the classical Hodgkin's lymphoma. So my question to panelists, and Smita being the only female on the panel, my request would be, would you treat patients who present with classical Hodgkin's lymphoma with an IPS of 5 any differently, or your approach would still remain ABVD?
I think you have to unmute, Smita.
Smita, can you?
Sorry, am I audible now? So presently we are treating at our center with ABVD all the advanced stage Hodgkin's and interim PET cycle 2, and then either escalating or de-escalating therapy based on the interim PET 2 response. Delivering escalated BCOP in our setting is a bit difficult for upfront therapy for these patients.
The reason why it's coming is, we know that brentuximab is still not available. It's not approved by the Drug Controller General of India, but we can import it. So people who are IPS 5 and above, do you see any role of brentuximab along with AVD, especially in the situation when we are, looking at high risk of relapse and lesser possibility of transplant in many of them later on? Any role for brentuximab?
I cannot comment on this now because the drug is not available, no experience in this use in the compassionate setting also. So data is there for upfront use. So if and when the drug is available, we can gain more experience, and maybe, that will be a therapy when the transplant is not available and the drug is cheaper and affordable.
Sure. So I'll take up Hari on the same question, and then I'll move on to the question, whether do you think, would you treat this patient any differently? And now when the relapse has occurred, whether any specific choice with respect to salvage chemotherapy?
Can you hear me? Hello?
Yeah, Hari, you're audible now.
Move the headphones. Yeah. She does have we would call it a high risk disease, and we know that brentuximab, if you look at the Echelon study, also the CR rates were higher, and early responses were higher. But when you look at whether we wanted to add brentuximab in this frontline setting, if you were to borrow a page from the German group where escalated BACOP was probably the choice that would have been used in this particular case, there may be a benefit of using, in this particular case, brentuximab in combination so that you get a higher CR rates. But I do not know whether we do have any concrete data that it would have been better to use brentuximab in this patient in the upfront setting, although there is a difference of about 5%.
Hari, your voice is breaking. Is it to me only, to everyone?
In terms of ADVD as compared. So, as with whether there is compelling evidence. Hello?
Hari, you're probably in a vehicle and you have, intermittent internet, and your audio is like breaking up in the middle.
So, so I'll just, maybe give Hari some time and move to Dr. Malhotra. Sir, what do you think regarding this situation? whether any difference in terms of frontline therapy than what we have done. And means theoretically, I understand that we may not have brentuximab available here. And same way for, you know,
I'll just log in through my phone. Okay. Just
I think I would tend
just
to
take go off, leave that,
Haru,
leave that.
Haru, would you mute your system? Yeah, thank you. Yeah.
I think I would agree with Dr. Smita that because we don't have brentuximab available freely, and the drug off the gray market is very expensive and infrequently available, I would go with the ABVD, standard ABVD for this patient, you know, of course, keeping in mind that this is going to be a high risk patient and the possible chances of success are going to be significantly less. Do an interim PET after 2 cycles, and if there is a suboptimal response, then, you know, shift to escalated DCOP without any hesitation.
Any opinions regarding salvage chemotherapy in this setting? I'll just take up, I think Pritesh is there, Lingaraj is there. Any opinions on salvage chemotherapy for this girl?
So Manju, can you please, unambiguously address your questions to one of us, because, you know, then there's this pregnant pause and nobody is volunteering to answer.
Sure, sir. So I'll point directly to Lingaraj and I'll say that, you know, Lingaraj, I need your opinion, and then we will move to Pritesh after Lingaraj speaks.
Thank you. Thank you, ma'am. So now the option of salvage chemotherapy in the relapsed Hodgkin, that I think the options have increased in recent past with the availability of combination of novel therapies with chemotherapy. So given all the choices that we have now, chemotherapy, brentuximab with chemotherapy, or IO with chemotherapy, I think if cost keeping aside, I think the best data available is IO with chemotherapy from the MSKCC, of combining pembro with gemcitabine based regimen, and then taking the patient for transplant. But if cost is a constraint, then I think the chemotherapy will be my first preference.
Sure. Pritesh, your opinion on this, and combining, if I mean, as I said, that we don't think right now that the cost is a constraint or the availability is a constraint. So based on data, what your opinion is, and then we'll tell you what we did.
Thank you very much. My thought would be to assess this patient for clinical trials if it is available. Otherwise, if clinical trials are not a possibility, then to go for, if CD30 is positive, then go for brentuximab nivo and then assess for transplant. If that is also not a possibility, then consider RICE or any gemcitabine based therapy in combination with IO. If that is not possible, then only plain gemcitabine based therapy followed by assessment for auto transplant. Of course, I believe that you said this is a first line failure. This is failure within 1 year. Is that correct?
Yeah, it's a stage 4 disease, failed ABVD within 1 year after achieving complete response.
Okay. Yeah, that would be the thought. That's a practice what we do here.
So as we didn't have, any better therapy, so we had started this patient on GDP. Post 3 cycles of GDP, she failed to achieve partial response and then progressed on therapy. So any different opinion now, Smita, to you, and then we'll take up the others, and I'll try to look at the pediatric perspective after that, if the similar case had come to a pediatric setting, because as I said, this is a little gray zone. I mean, though it's not typically less than 18 years, but 20 years.
So, Dr. Manju, we are also using GDP as a first-line salvage chemotherapy for most of our relapsed Hodgkin's, and we tend to get a response of close to 70 to 80% in these patients, and we are able to take them for transplant. In a situation of no response to GDP, our second line is nivolumab plus bendamustine for these patients before we take them for transplant. So, not much experience on this, but so we had some couple of 4 to 5 patients who had got nivolumab in different settings, nivolumab plus bendamustine. Or if that is not feasible, a second line salvage therapy with ICE.
Okay. Dr. Gaurav, if this was in your clinic, and let's presume this is less than 18 years rather than keeping that 20 years. Any difference from the time the patient first presented to their management now when they have failed, she has failed the salvage therapy?
So I'll of course answer what we do, but I will also add the rider that I definitely think that in hematolymphoid malignancies, what works till 15, 18 years of age works well till 20, 25 or even 30 years of age. So yes, we would treat differently frontline. We moved nearly a decade ago to the German pediatric oncology and now the Euronet-based system of using an OIPA backbone up front, followed by radiation to bulky sites. And we have demonstrated a much improved EFS as much of the world which has adopted this regimen. Because to us, the question for frontline therapy now is no longer curability for Hodgkin's, it is long-term toxicity. And especially the younger the patient, you have to be more sensitive about long-term toxicity. So with that in mind, we think that ABVD for anybody who's going to require more than 2 to 4 cycles of ABVD, it's not justified. The younger the patient, even more so. Having said that, on the more intensive chemotherapy backbone up front, there is the EFS is better. So the chances of facing the situation have reduced in the last 10 years. So we are facing the situation less and less now, what you described. But if the patient had relapsed like the way we did, I agree we would have done the same. We also would use a gemcite-based regimen with the intention of going for transplant. Because what we see is that the remission is for prompt, or within 1 to 2 cycles you can usually get a remission, but after that it is not sustained. So if you can go for transplant, then the idea would be to use a gemcite-based regimen, and after the second or third cycle, once you have a remission, do your collections, and by the fourth or fifth cycle, go for transplant. Unfortunately, that did not happen over here, and I think it's only now probably that our approaches would converge to what is being discussed.
Sure. So if I can sum up, we don't have the brentuximab available as of now, and that decides our treatment choices. For frontline therapy, majority of us continue to use ABVD as our frontline therapy. Certain centers have started using escalated BACOP, including ours in some of these patients. And you decide your treatment. If you're using ABVD post 2 cycles, we need to assess response. If it is complete response, you continue with ABD. And if it is partial response, then you change over to a BACOP-based regimen as your response adapted therapy. Use of brentuximab in frontline, the data is there for the IPS 5 to 7, but the trial had its own issues. Though, if you look at even the revised analysis which they did, brentuximab has made a difference to an absolute improvement in terms of PFS of roughly around 5%. So that's what is the data. Regarding the salvage, as most of us, again, because of lack of availability of brentuximab, continue to use conventional chemotherapy. But as Pritesh said, that the best responses which are known is brentuximab nivo, 4 cycles, you get a CR of roughly around 67%. Brentuximab alone, followed by chemotherapy in those who fail to achieve CR, is roughly around 30%, and then you take them up for ASCP. The challenge comes if they fail, the conventional chemotherapy and transplant, and then you see this situation of disease progressing. Then the question comes whether it's brentuximab or nivolumab or checkpoint inhibitors. So I think the data favors the checkpoint inhibitors at present. If you look at the head-to-head comparison, the question comes how long. For nivolumab, the duration is not defined, whereas for pembro, it's 2 years. So, but the cost of pembro as compared to nivo as of now is higher. And therefore, many of us continue to use nivolumab in this setting if there is a feasibility for checkpoint inhibitor, because still the cost is prohibitive. So with that, I'll move on to the next case. So this is a 50-year-old lady who's hypertensive, diabetic, on OHA for last 7 years. She's been diagnosed with diffuse large B-cell lymphoma, not otherwise specified. She has stage 3 disease, no B symptoms. The disease is nodal with bulky retroperitoneal nodes, and there is colonic lesion which is present in the ascending colon. So she's treated with R-CHOP, And post cycle 4, she had DS4, and which continues to remain the same even at the end of 6 cycles. Unfortunately, there is not just single site of residual disease, it's multiple sites of residual disease. And the biopsy was done from the residual lesion, and it shows DLBCL, which still continues to express CD20 even after 6 cycles of rituximab. So the question is, what would be your preferred second-line therapy? And I'll start with Dr. Hemant Malhotra this time.
Thank you, Manju. I think in this patient, the first thing I would do is explain the prognosis to the patient. The patient has not responded to 6 cycles of R-CHOP, has biopsy proven residual disease. So she obviously needs more chemotherapy and an auto transplant. My choice of a salvage regime would be R-ICE. I actually don't like R-DAP. So I would try and get her into a remission and then, think of doing a high dose therapy with an autologous rescue. So that would be my plan in this 50-year-old patient.
I'll go back to Hari if his audio is better now. Hari, what would be your second line choice in this patient, and any difference in terms of how you would treat this patient in frontline?
Thank you, Manju. The problem that we have over here is that she is probably a primary refractory, and we know that in that situation, even when you look at the, as Hemant sir rightly said, whatever we do, it's about 26%. Is there a lot of background noise, Manju? I'm sorry.
Yeah, we can hear Vishnu, Hari.
Sorry. Can I just take the question a little bit later, because
no
some
problem.
issue. There's some issue over here. Yes.
No problem at all, Hari.
Sure.
So I'll move on to Smita. Any difference in terms of your choice of second line therapy?
No, Dr. Manju, we also do RIs as our second line therapy, but as Sir had said, these are a set of patients who do very poorly primary refractory DLBCL. Even after autologous transplant, we don't have any survivors. So we need something different for these patients, maybe in future CAR T cells or some other different approach. But as of now, we are doing RIs with very, very poor outcomes.
So I'll go back to Vipul. Vipul, what is your opinion in terms of the preferred second line therapy here?
We group treats leukemia, not lymphoma, so I have no additional comments.
Sure, no problem. I'll come back with the leukemia question to you. So, any difference of opinion from anyone? Otherwise, we'll tell you that for us, we use GDP as the preferred salvage regimen along with rituximab. Given that it's much easier to handle in terms of its toxicity, so RGTP is what was given to this patient, and after 3 cycles, there was partial response. And next step is what we should do in this situation. It's a PR. Again, it's not a single site which is residual. Again, at all those multiple sites, but it has reduced as compared to what it was before starting RGDP. Dr. Hemant Malhotra, and then go in that cycle again.
Okay, I was just about to ask if the question is for anyone.
You want to take up, you can take up.
Yeah, Manju, you've been
after Dr. Hemant. After Dr. Hemant.
You can ask Reena something.
Oh, okay. sorry, sir.
Thank you so much.
Sorry, I didn't get you, sir. What you were saying?
I was saying that you're being partial to me, and I mean, I have no problem in answering this. I think I would give 3 more cycles of RGTP as she's shown a partial response. Try and augment that response if she's tolerating the chemo well, and then I would do a high dose treatment for her with autologous stem cell rescue.
So I'm not sure whether I'm allowed to ask questions to the chairperson. I can see Dr. Reena here. So what would be your approach to this, madam? Because Dr. Hemant said I'm being partial to him and asking questions only to him.
No, as a chairperson, I have the right to listen to all of you. So, I mean, just that it is immuno-oncology, and we have so many drugs which are not really available over here, but they are available in compassionate-based access. So we normally give the chance of getting polatuzumab for these patients, and we have seen some good responses. Most of them have been in the third line, but I have no doubt that if a patient has a resistant disease, I will try to kind of bring it up front and see that this patient goes into a quick response before we take him for an auto transplant.
Sure. Lingaraj, any difference of opinion? Would you take up now for auto transplant with the PR and RGDP, or you would want any different therapy before taking up for transplant? And then I'll come on to our CAR T cell man and I'll ask what is his opinion.
Thank you, ma'am. So I think if the patient has attained a partial response, I think the quality of partial response also will matter. I think there is a bit of subjectivity when people say it is a partial response. So what is the largest diameter of the node of the residual disease? So in the recent CIBMTR data of CAR T versus transplant has shown transplant and CAR T are more or less same if you have a partial response. But when they did dissect out that the patients with transplant arm has lesser burden of disease. So it will matter how is the burden of disease, and I definitely will try to get a CR. But if the CR is not possible because any kind of novel agent is not feasible in this patient, so probably if the disease burden is very high, transplant is not a good option. But if the burden of disease is less, I still go ahead and do a transplant given the outcome of say 20 to 30%.
Sure. Gaurav, you wanted to add something.
Yeah, actually, just the point which Dr. Reena was also making, that since it is a immunology meet, the good thing about immunological targeting is that it blurs the age boundaries. So I feel confident on talking about a 50-year-old DLBCL2 because still chemotherapy, our approaches can be different, but immunotherapy really it's just by what's on the tumor where the age starts becoming irrelevant. Going by the study which I think Lingraj referred to, I think that's a retrospective data, and that you already rightly pointed out in that the patients who went for got CAR T was definitely, they had the higher tumor burden. The worst prognosis patients got CAR T out of that. So it will be a bit disparate to probably compare that data. It should be tested out prospectively, maybe. What we do know is that from here on, from this point where you describe this patient, RGTP 3 cycles and partial response, from here on we know the prognosis is very poor. I have not seen any long-term study showing decent long-term survival, even with transplant from here onwards. I think from what we have seen, it's probably between the range of 20% or 30% or lower. Correct me if I'm wrong. Most of these studies were in adults. So here I definitely think that this is a candidate at this stage itself for CAR T. You heard in the previous talks that the quality of CAR T, the cells, is also important. The further down the treatment timelines you give it, the more likely they can be exhausted and cause a less durable response. So this is definitely a factor. I would not wait. I would, if the patient could be eligible for CAR T and the availability is there, this would be the point to be going for it, as my opinion.
Yeah, madam, can I just interrupt here and ask Gaurav sir that what is your thought that sequencing transplant and CAR T? So suppose this patient goes for a transplant, he will relapse. I know that, no, the chance of relapse is very high. What if I use CAR T after transplant rather than using now? And suppose we know that long-term outcome of CAR T also is 40% in this patient, 40 to 50%. So what is your thought on sequencing of CAR T and transplant?
I don't think there's any data on that yet, at least from lymphoma. I mean, at least any large scale data. So, the DLBCL trials did include patients who were transplant failures. And they also had long-term survival. So same way for the ALL also, there were so many patients included in the initial trials who were transplant failures. What you have to realize here is that this comparison is really apples and oranges actually, because the CAR T trials being all early phase trials so far, you don't have a phase 3 randomized control trial here. You all are early phase trials, and in early phase trials, it is the worst prognosis patients who got included.
Your inclusion criteria teases out the patients who are eligible for other therapies. So you're really taking last end of the line patients. And when you see such 40% outcomes in that, it's logical to, there's a strong basis here to take it earlier of the timeline. Definitely. So those trials are being done now, definitely for leukemia. Now CAR-T is moving into first line, that is in the refractory setting, initially itself after 2 cycles, and COG is going in for a trial for that. So people are moving very rapidly up the timeline with CAR-T because of the treatment and the difficulties involved in giving it, subsequently down the line. So in theory, yes, it can work, what you're saying.
I think Smita has raised her.
CAR-T followed by transplant. CAR-T followed by transplant may be a better option rather than the other way around.
Smita has raised her hand. Smita, anything you wanted
Yes,
to add?
Dr. Manju, may I ask a question to you? Is what is your opinion and experience on allogenic transplant at this point of time for these patients?
So I don't think DLBCL, the results of allogenic transplant are any great, and especially if you're talking in terms of PRs, it's not really very great to transplant these patients and do allogenic stem cell transplant. Here is what we have seen. Just to add to what I think Vipul has raised his hand. Vipul, you wanted to add anything?
Since I answered nothing, can I ask one question to the panelists?
Yeah, I will. We'll come back. I think Dr. Malhotra wants to add anything to this, and then I'll just sum up the entire thing for this particular case, and then we'll move on to the next, because I'm waiting for Dr. Bakshi to be coming in for leukemias.
Thanks, Manju. Very happy to be your favorite on this panel discussion. You are my favorite person too. So, like, my quick question is to our CAR-T man, Gaurav. Would you prefer that the patient be in CR before you consider CAR-T, or would a patient in partial response, as is Manju's patient, would be okay, and you have the same results or similar results?
So actually, that's the whole thing. For CAR-T, you do not require a remission, and for transplant, the data is quite clear that if a patient is not in remission at the time of going for transplant, both for leukemia and for lymphoma, that the results are not good. In fact, they are low enough for it to be redundant to take a patient not in remission up for transplant. So from this point onwards, where patient has received 2 lines of intensive chemotherapy and is still in partial response, the chances of being able to put into remission before taking off a transplant is very, very slim. That's what reduces the chances of the transplant being successful actually. It's not that transplant itself is bad, it's a great choice. The other way around works. So that's why I said it's comparing apples and oranges, because you use them in different settings. You want to do transplant in a patient in remission. You can do CAR-T in a patient who's not in remission. So you don't require in fact, the not being in remission is what stimulates the T cells to proliferate and engage. So probably doing CAR-T in remission, we haven't studied that yet. Though some patients, by the time they've been infused with CAR-T, have been in remission, so we have data on that. But apart from that, it's not been studied as a study objective yet. So that's what I would say.
That's an extremely key point, that for a patient who is primarily refractory, this patient is unlikely to have a complete response to chemo. Then we need to get the car up front rather than the transplant. So, get the Indian car on the road quickly, Gaurav.
So we are going full steam ahead, but it's a phase 1 trial, so there are reasons why we can't go fast. That's all.
So just to sum up, as Madam said, that it's an immuno-oncology meeting and we need to talk on immuno-oncology. So there seemed to be some excitement as far as frontline therapy for DLBCL after a long time. The combination of polatuzumab with R-CHOP seems to have met its endpoint, and it will probably be presented in ASH. So we may see a different, first-line standard of care over a period of time, but let's wait for the result.
We have to wait for the day for R-CHOP to be dethroned.
But I still love the regimen.
I really don't think that is going to happen, Gaurav. That will not happen.
I don't think it's going to happen. That's what I meant. I didn't mean it slightly cynically.
The second thing is regarding the relapse and the management now. As Madam said, that polatuzumab again here, the data is mainly as of now restricted to the transplant ineligible subject with pola plus BR. This is the evidence. The POLA plus R-GEMOX versus R-GEMOX POLAR GO trial is ongoing, and we should have the result. But yes, it does work in patients who have, who have not responded earlier to rituximab-based therapy. That's one option. Still, RGTP remains the favorite regimen when we are talking in terms of relapse setting. The situation is difficult when you achieve partial response, because we know that ASCT is not going to, means that's a choice, but that doesn't help much in these patients, with majority coming back pretty quickly after transplant. On the debate on CAR-T versus ASCT as part of this second line treatment, I think except for the Belinda trial and the CIBMPR data, which was negative, the two other trials with two different CARs have shown positive results in terms of the event-free survival in this particular setting. So, which is ZUMA-7 and the Transform trial, there is positive data. And the main difference which was there between Belinda and these two trials is the use of salvage chemotherapy in the Belinda trial, versus in the other two trials, they went ahead directly with the CAR-T cell therapy if you're looking at second-line therapy. So that again brings the same question, that doing BMT before CAR-T will not be a great idea, because that's something which is very similar to what we are doing with salvage before CAR-T, and that will add to the issues later. Quickly, I'll move on to the next case. I'm not sure how much time we have now, because
5 minutes, ma'am. 5 to 6 minutes.
Great. So then I'll move on to the next case, and this is going to be Dr. Bakshi, Vipul, and Dr. Gaurav. So it's a 16-year-old female with pre-BALL, high-risk disease because of the high counts at presentation, as well as hypodiploidy. She was treated with BFM90, post-induction remained MRD positive. She was planned for allergenic stem cell transplant, but because of some logistics, it was a bit delayed. And while in the first month of maintenance therapy, she developed, peripheral smear started showing blast. So she had medullary relapse after just at the start of the induction. So how would you approach? And I'll start with Dr. Bakshi before I come back to others.
So thank you, Manju. So my first comment is that planned for allogenic transplant based on MRD positivity. I have two comments here to make. One is, there is no data actually to say that for a MRD positive tumor transplant actually helps. One may try it out, but there is no data that conventional versus transplant will be better. One would still continue, and probably in the case of pH positive ALL, if they were MRD positive, you continue consolidation. If they are still MRD positive post consolidation, then the role of transplant is shown to be beneficial. If they are MRD negative post consolidation, even in a pH positive ALL, in the pediatric age, transplant versus continuing TKIs would give a similar outcome. So that's number 1 point. In the second case, now that the patient has relapsed, so the approach would be to go for a salvage second line therapy and on a relapse protocol, and hope that this patient becomes MRD negative, and then go for an allogenic transplant. That would be the standard approach. Your question may come next. I'm pretty sure that this patient is MRD positive after the salvage reinduction regimen. Then what to do? Let's see what questions you have, but I'm sure that would be your next question.
Sure, sir. So before I move on to that question, I just want Dr. Gaurav and Vipul, whether there is any different approach. So first Dr. Gaurav, followed by Vipul.
No, I fully agree with Samir. So, we would not take a transplant decision based on post-induction MRD positive anyway, unless it was a frank induction failure. Even with high-risk cytogenetics like pH, etc., we would now, in an induction failure, add a TKI. Otherwise, we would wait for MRD-based decision. We would wait till the post-consolidation time point. So fully agree with that. And and also, yes, so that's, you're not asking about what to do now after that, right now, are you?
So I'm just waiting for Vipul to answer, and then we'll move on to that question. That's okay. Post-salvage, yeah. Vipul, anything you want to add here?
So whatever has been told about chemo, I have nothing to add in that, because that is what we do in India. But since Brina and INO is easily available here, we will always include that agent with chemo since it's 16 years old. So we combination, and we would prefer to give INO if blast percentage is more than 60%, less than 60% Brina. Brina is not so great, it takes time, mainly for MRD positive disease, but we'll try to introduce both the agents with chemotherapy or take CAR T cell approach, because nowadays, like, we'll try to avoid Blina if you are giving CARs, or ENO if you are giving CARs, because you also have CD22 CARs. And anyways, CARs is a bridge to transplant. So either of those three approaches with chemotherapy.
Thank you. So as Dr. Bakshi said, yeah, we did not succeed with salvage chemotherapy. There is still significant residual disease. So what would you do, sir, at this time point?
So may I know when you say significant residual
So
disease?
she's still not in morphological remission?
Okay, if she's not in morphological remission, then the question gets pretty complicated. If it was in morphological remission and just MRD positive, in our setting, I would have thought differently. But now that there is no morphological remission, I would agree that what Vipul said, one would have to go with an immuno-oncology approach to achieve a CR. So that would be the approach. Now the question is what the patient can take. I would certainly think that CAR T cell here would be a very good option to take in this setting if the patient is not in morphological remission.
Gaurav, any difference of opinion here?
So I agree in principle if now post the patient having had a high risk early relapse, it has to be chemotherapy, achieve remission followed by transplant. Now, if you have given chemotherapy and not achieved remission, then part 2 of the objective still remains, and that is achieve remission and take to transplant. So now the question is, what will achieve the remission? Quite clearly, a patient who has had an early relapse, post-induction MRD positive, early relapse, the moment intensive therapy is got over in maintenance, first maintenance also relapse, and now refractory to, this is a chemo-refractory disease. You don't require any more evidence to say this is chemo-refractory. So trying to chemotherapy approach from here on is, there is no, it's a one-way street. So it has to be a non-chemotherapy approach. So that leaves us with the 3 options which have been mentioned here. So there's inotuzumab, there is blinatumomab, and there is CAR-T. Well, the data now after the ALL 1133, I think, the 2 3s and 2 1s in it, trial from COG is now very clear. So now in this situation, the standard of care, that trial had to be closed early because the endpoints were met with such stark differences and reduction in toxicities that today the standard of care in this situation has to be considered as blinatumomab. So this patient should get blinatumomab followed by transplant would be the best option. That's the standard of care. Other options you can, if you have the availability, if you think that you can use a anituzumab. Most of the early data has come from the adults. Now the pediatric data is emerging, but I think 16-year-old would qualify. So definitely anituzumab, but there's a risk of VOD which you get with that, which can be compounded, especially if you're taking the patient for an allergenic or a haplotransplant subsequently. So I think all these factors come into play in deciding what other agent to use. Standard of care after the COG trial will be right now blinatumomab followed by transplant. Everything else is what you will be able to do if you can't do the standard of care. The CAR-T is an option over here right now and on trial. It would be an option. Or a patient not eligible for blinatumomab would also be an option. Would be eligible for CAR-T over here.
So, Gaurav, just to continue on that, if post-CAR-T she achieves MRD negative remission, would you proceed with the allogenic stem cell transplant or?
Yes, we would. So, the difference now, like I said, the principle of therapy at this stage with this patient has to remain achieve remission followed by transplant. And in that context, you must look at CAR-T also as a means of achieving remission where chemotherapy failed. So if the patient can go for transplant after CAR-T, patient must go. What we do have is that a lot of patients who were not able to go for transplant after CAR-T showing long-term remission. Now that's good, but that should not be the recommendation because the improvement in outcome is by nearly 15 to 20%. And I think Rahul has referred to Nirari's recent paper also, which was nearly a 30 to 40% improvement in outcome between those who underwent transplant and those who did not. So it is very good for a patient who had no chance of cure to have a 50% outcome without transplant post CAR T, but it is even better if they have a 70 to 80% outcome post transplant post CAR T. So we should not recommend the patient not to go for a transplant, but we can accept that the patient may not be able to go and still have a very good outcome.
Thank you. I could hear those
Manju?
words, yeah, from the organizers. So I think we have to. Sorry, Hari, we have to.
Manju, can I just talk about a little bit about what has been? I agree with most of the things that have been accepted, and I strongly feel that achieving an MRD status before a transplant is extremely important. And one of the ways to get that MRD negative status is probably to use blinatumomab or inotuzumab over here. And of course, if we can, if there is a morphologically present disease, then certainly those are the situations where definitely CAR T cells have to be looked into. But I just wanted to share two patients whom we used inotuzumab, and both of them in the pediatric age group, and one was 17 and another patient was 14 years old, relapsed disease. We managed to get them into remission, and then they were MRD positive with inotuzumab. We got them into MRD negative status following that. But one of the patients, subsequently, we took him up for allo transplant. He had a complete chimerism, but unfortunately, the patient relapsed in the extramedullary setting. He had extensive extramedullary disease, and this was by day 120 post-transplant. And the second patient, on the day that we were taking up for transplant, he developed CNS symptoms, and the patient had extensive CNS disease. So many of these, like inotuzumab and blinatumomab, they don't take care of CNS disease, while the CAR T cell therapy has got an impact in taking care of CNS disease. So there is certainly a way of sequencing these things for optimum outcomes. And I think eventually, wherever there is a possibility of doing a transplant, one needs to look at that as a culmination of all the sequences of treatment that we go through.
Thank you, Hari. Thank you for those, inputs based on the clinical experience.
Prove it.
Yeah, I can see there are questions in the chat box. So my apologies, I didn't read them before, but I guess we are run out of time. So thank you, everyone. It was a great session, great inputs. Thank you, and I'm handing it back to the organizers. Thank you.
Thank you, Dr. Manju.
Thank you.
This was a great session indeed, and very intense discussions as anticipated, and questions will go on. But as you know, we need to respect time. So the last word I want to hear from Dr. Reena Nair, who is a mentor and teacher for many of us. So, Madam, please sum up this session, and then we'll move on.
So interesting cases and thought-provoking answers. Since, like I already said, it is an IO day today, so we will stick to conclusions on the immuno-oncology front. In lymphomas, there is no doubt that a lot of these drugs are now available on compassionate grounds. And so while we wait for CARs to be available for all patients, I would recommend that most of you should have access to these drugs. We have the anti-CD19 also. We have bispecifics 20 and 3 available. And so most of these patients should be put into a remission as early as possible, especially those who have partial responses. We can't take them in second line and keep waiting for the disease not to go away and then have these patients actually succumb to the disease. I think it is quite available and results are good. Again, CAR T, of course, in the DLBCLs initially was not as encouraging as it is becoming now, and so we will need the modern CARs for DLBCLs to be to use them effectively. In ALL, I completely agree with what Vipul and Hari have tried to summarize. If you have a patient who is MRD positive, as early on, get your IOs to put them into an MRD negative status and take them into a transplant. And again, available on compassionate grounds, so you can use, like Hari, I think Vivek has already published about 7 patients. We seem to have had reasonable luck with putting them into an MRD negative status and then taking them on for an allogenic transplant. So thank you for the excellent cases presented by Manju, the great answers that we got, and I think most of all to Jyoti for actually making us think much ahead of our times and trying to get these drugs by what I would say is, beg, borrow, or steal, put them into your patients so that many of these curable diseases actually become curable for patients who don't initially respond. Thank you very much.
So thank you very much. And this brings us to the last day of the third annual Congress. And I'm extremely delighted and very much humbled also and wish to thank each and everyone who actually contributed for this successful ending of this meeting. So the overseas speakers who actually honored our invitations and taken out time from their very busy schedules, national faculty members, my co-organizers, team IOSI, all the participants, event team and sponsors. And with this, I will invite Dr. Amit Avasthi, who is my co-organizer, and he will deliver a formal vote of thanks. So thank you, everyone.
Thank you, Jyoti. So first of all, I would like to, on behalf of the organizer, Dr. Atul Sharma, Dr. Jyoti Bajpayee, and myself, I would like to thank all the participants who actually did really, I mean, this was, to my opinion, and perhaps you all agree with me, that it was one of the great scientific feasts we had last 3 days. And we actually learned not only the clinical aspect, but we also learned a lot about new upcoming and emerging data on the basic sciences. And I would like to take this opportunity to thank both our oration speaker, Dr. Takashi Honjo and John Hannon. I mean, in fact, we really wanted Dr. Honjo to be on live, but however, due to some emergency, he had to, provide us the recorded video. But really, his talk was great. I mean, we learned some of the new upcoming therapy, which could be adjuvanted with the PD-L1 and PD-1, what Dr. Honjos actually indicated in his recent publication, what he has presented, published in the PNS. I also like to thank all the keynote speakers, Linda Chin, Vijay Kuchru, James Lurkin, and all, who actually did a wonderful presentation and provided all the new emerging data in their field. And this was really kind of very boosting for all of us to move forward into IOSI. I thank all the chairperson for taking the time for chairing the session, and all the lead discussant. Actually very important because they picked the right question in order to save time, and I think all our session actually went on time because of the chairperson as well as the lead discussant. So thanks very much for these very important people. I really thank River Route, especially Rekha and Nimesh, for providing glitch-free sessions very smoothly. All the session actually went very, very smoothly. And I further would like to thanks, last but not the least, actually our sponsors, BMS, AstraZeneca, Pfizer, for providing a funding support for this great scientific feast. I'm sure that IOSI will have opportunity to work with them in future. And I also like to really convey our sincere thanks to the executive committee of IOSI, and then President Dr. Subha Chiplonka ma'am and Vice President Dr. Hemant Malhotra for providing all of us, I mean, 3 of us, giving this opportunity to organize this virtual conference. In fact, we really wanted to go semi-virtual mode because we were thinking that COVID is actually going away. And then suddenly the second wave actually came, and we were thinking maybe third wave will come. So therefore, after a lot of discussion among ourselves with Dr. Jyoti and Dr. Atul Sharma, we decided to really come forward for this virtual meeting. And in fact, it went very well. I'm very, very happy. And I really like to especially thank Dr. Jyoti, who took really a lot of effort. In fact, sometime I myself was here and there busy, but I think I really thanks Jyoti and Dr. Atul Sharma for this wonderful conference. And thank you very much. I'm myself and maybe all of us actually looking forward for next year conference. We are so excited for new data, and especially the data from Girdhari. I'm really excited for that. That spatial cell he did not mention. He said cell A. So I'm really looking forward. What is that cell A? And maybe some clinical trial data will come from Dr. Rahul, and very exciting. So looking forward for next year conference. Thank you very much. Thank you, Jyoti and Dr. Atul, up to you.
Thank you very much, everyone. Great work.
After Dr.
by all
Atul's
of us.
note, we can have a picture. So please on your cameras as well.
No, I just wanted to thank each and every one of you. Probably, I think Jyoti, Amit, and all others involved in this great meeting. Excellent speakers, on time, 2.5, and probably maybe next year we'll have a physical meeting somewhere in a good place. Probably we can meet, chat, and this. Okay, thank you very much. Bye bye.
So can we have a camera on? Who all can do that? And Rekha, you can click a picture.
Jyoti, I'll quickly sum up.
Yeah, please, ma'am.
Basically, it is to thank the 3 enthusiastic organizers. You all have done a wonderful job. It was great listening to all the talks, well managed, a wonderful meeting. And I'm sure every year we'll continue doing that. Thank you.
So Rekha, we can click a picture who all can on the camera. My request, if everybody can on, but otherwise whosoever can on. So just click.
Done, ma'am.
Thank you very much. Thank you very much, everyone.
Thank you.
All right, bye bye.
See you, next year on the same month. I cannot say the same day and same time.
I think we have GBM also 2 p.m. right?
Yes, that's true.
Yeah, GBM 2 p.m. Yes.
Yeah.
Thank you very much.
Thank
Bye
you.
bye.